of organ transplantation, both private and government institutions, belonging to both private and government institutions, the transplant coordinators and other delegates, a very warm welcome to you all. On my personal behalf and on behalf of Transplant Authority Tamil Nadu, today we are going to have a CME with topics encompassing almost all organ transplantation. It's a bimodal CME. There are many colleagues are watching virtually. It is live streaming is done through YouTube. In spite of being a second Saturday, I profusely thank you for spending your time to attend this important academic event. Academic updates is very important in any aspect of medicine, practice of medicine, but particularly in the arena of organ transplantation as well. And each organ transplant has got its own nuances. Overall, the transplant medicine is a modern day marvel. And in each organ transplantation, the challenges are unique and each one has got its own intricacies and so on. So just to share ideas and spread the message across, these kind of update sessions are absolutely important. That way, so we thought of organizing this, and so thanks for accepting our invitation. To start with, we are a bit delayed, so I thought the time allotted for me is 30 minutes. So I'll finish my talk briefly so that we don't lose our time. So another 10-15 minutes, I'm just going to give a glimpse of the situation of organ transplantation, the disease donor transplant of Tamil Nadu during the previous year, that is 2024. So most of you, who have been following this program keenly, nothing new. So 2024 was a real, a remarkable year for the transplantation in the sense that Tamil Nadu registered the record high number of disease donations of 268, and this is a huge number considering the previous records. It's a record high number during one calendar year from one state ever since the program started in India. And there are some unique phenomena in this. It is not just the number. The organ utilization rate. So out of these 268 donors, 863 major organs, 637 minor organs and tissues. So in total, 1,500 organs and tissues were retrieved and successful. Not just that, there is a government and private sector contribution. Both have been very impressive. This is the first year the contribution from government institution exceeded that of private institutions. 54.48% of the donors came from government institutions and 45% came from government institutions, private hospitals. Not just that. All these long years, majority, almost all the donors were actually victims of accidents and trauma and so on. This is the first time there is a significant number of non-RTA donors. As you can see, the split up of the numbers. 186 were victims of road traffic accident and other trauma, and 82 were from non-RTA. So I would like to highlight this particular point because, now post-COVID, there is tremendous improvement in emergency care and critical care in almost all the institutions across the state and government sector, not only teaching hospitals, but also the district headquarters hospital and so on. So everywhere there are the medical causes for brain death as well, and there's a lot more sensitization that has to happen. That is happening. Fine. And this is the split up of, so this is the record of the number of donors from 2008 onwards. That's it. So in 2024 was the record high number. The kidneys were 456 and liver 210, 96 hearts, 89 lungs, and 3 pancreas, and 6 small bowel, and 3 hands. Fine. So how this impressive performance became possible? Of course, it is the collective efforts and contribution and nice cooperation among all the stakeholders of the program, both government and private sector. Very strong political support, the policymakers' support, and unflinching support from the bureaucracy and the technocrats, medical and paramedical staff of all the institutions across the state of Tamil Nadu, and a very strong support from both visual and print media. And most importantly, the public of Tamil Nadu, they are so unique. The acceptance rate for organ donation from Tamil society is far, far ahead of the rest of the country. That by itself is a subject for a research as to how come the acceptance rate is so high in Tamil Nadu. Based on our subjective sensation and experience from the major hospital, Madras Medical College, the acceptance rate for organ donation, even with just one counseling, is around 70%. So when we discuss with our colleagues in other states, actually they are really wonderstruck. So this is what is happening. And for those who are not aware of this, again, I would like to reiterate, this is a historic government order passed in 2023, month of October, on the instructions of the Honorable Chief Minister of Tamil Nadu, that every organ donor will receive the honors on behalf of the state government of Tamil Nadu by none other than the collector, the sub-collector or district collector, or a top-ranking official at the district level, not below DRO. And it was, this order was passed in October 2023. To this day, 483 such state honors have been accorded to the deceased donor families and deceased donors. So this has really resulted in the percolation of the information across the country, nook and corner, across the state, nook and corner. And even if the donor's family is in a remote village also, the corresponding collector, sub-collector, he or she reaches the residents, and without any fail, without any hassles, this has been happening. This is one major step. And understanding the impact of this particular GO, many other states like Andhra Pradesh, Odisha, and recently Puducherry also have passed similar government orders. Fine. So a quick glimpse of how the different institutions fared in 2024 or contributed. So the top 5 performing government institutions in 2024, Madras Medical College, Rajiv Gandhi Government Hospital, 28 donors. And thanks to the team MMC, I was also part of that team for the first 1.5 of that year. I can also take a little bit of credit. And the core team members, and Dr. Gomati and Dr. Jayanti, Dr. Raghavendra is not here today. They received national award as a best brainstem certifying team of South India. And next was Tanjavur Medical College, and then Madurai Medical College, Dharmapuri Medical College. Dharmapuri Medical College, despite being a non-transplant organ retrieval center, they don't have the facility to perform organ transplant, but still Dharmapuri is one of the best performing non-transplant organ retrieval centers. And then Tirunelveli Medical College. So these are the top performers of 2024. Out of these top 5, 4 are transplanting hospitals. There are 13 government medical colleges where the transplant activity is there. At least kidney transplant is taking place. Dharmapuri, non-transplanting organ transplant retrieval centers. How about the private sector? In 2024, the maximum contribution came from Velammal Medical College Hospital, Madurai, with 22 donors. My appreciation to Velamal Medical College Hospital, Madurai. The second is CMC Vellore with 9 and SRM Medical College, Katangulattur 9. Mayot Hospital, Chennai 9 and Kovai Medical Center, Coimbatore 7 and Apollo Hospital, Chennai 7. So these are the top performing hospitals from the private sector. And a word about NTORCs. We have, as I've already said, there are 13 medical college institutions performing transplant, but we have 36 government institutions. So what the government did is that government made all the teaching institutions. In addition to that, there are some high volume district level hospitals. They gave, the government in one order gave license and permission to all these institutions as NTORCs. That was a major step. So now the transplant activity is no longer Chennai centric. It is not just confined to some major institutions of Chennai. Now the activity is spread across the state. So this is a greater inclusivity and equity and distribution of the transplant activity across the state. That's what is happening. So this is the comparative with all these newer measures, newer initiatives of the government and other sectors. So this has been the impact. The comparative performance between 2023 and 2024. In 2023, there were 178 donors, whereas in 2024, 268 donors. And number of organs and tissues wise in 2023, all the major minor organs and tissues put together, it was only 1,000, whereas in 2023, it is 1,500. This again is the highest number in the country, and you all are aware that Tamil Nadu received the best performing state award from the NOTO. It was given away by the Honorable the Health Minister of Government of India a few days ago in Delhi. Fine. So what is the current status in 2025 from January till now? Now there are two government institutions, they are neck to neck. They are just, there is a healthy competition kind of a thing like Madras Medical College and Tirunelveli Medical College. Both these institutions have certified 18 donors so far. 18. And a great appreciation should go to the institution Tirunelveli Medical College. Of course, my appreciation, a lot of affinities towards MMC is always there. But you know, like, in spite of being a major medical college, I mean, this kind of a tremendous performance on par with MMC, it is definitely deserve appreciation. That shows the commitment of the people around there, the dean and the certifying team and the maintenance of the disease donor team. It is a formidable task in any government institution nowadays. The workload is just overwhelming. The number of outpatients, thousands, and the bed occupancy rate is always 100%, and a lot of emergencies, and more of dependence of the lower and the middle class of the society on governmental institutions. Despite this, according importance and giving priority to this diseased organ donor program is something really to be appreciated. Then Dharmapuri again, 7 this year, and E-Road Medical College, Perunturai, 7. The key person sitting here, Madam, please get up. She deserves appreciation, and this again is an NTORC, Non-Transplant Organ Retrieval Center, but under her leadership and with the guidance of the dean and the team, they have certified 7 brain deaths so far. Even though they don't have the transplant facility, they identify the brain death and certifying. Thank you so much, madam. I hope you continue your good work. And then Tanjavur Medical College 6 and Madurai Medical College 5 and Trichy Mahatma Gandhi Medical College 4 and Coimbatore 3 and so on and so forth. So this is the scenario on the government sector. How about the private sector? This year also, so far, Velamal is in the top position with the 12, And again, CMC Vellore is retaining the second position, 7. Kobe Medical Center Hospital, Coimbatore, 7. Mayot, 6. Apollo Hospital, 3. And Dr. Rela, 3. And Ramakrishna Medical Center, 3, and so on and so forth. So this is the scenario so far in 2025. So why I am projecting this data is that even though this year performance is almost on par with the previous year performance, I have a personal impression that we have developed some kind of complacency, and I think it's going to be a kind of a plateauing. This should never happen. There's no room for complacency. Awards and rewards are okay. We have to just relish on that, and we have to just cherish those moments for a day. That's all. We have to be looking ahead. Why? Because the huge wait list for organs, the widening gap between the demands and supply is increasing not every day, it is every moment it is increasing. The number of patients who have registered themselves for kidney is more than 7,500, and for liver more than 500, and heart and lungs and so on and so forth. And this organ failure is increasing not linearly, it is exponential increase. Exponential increase. Even though Government of Tamil Nadu has initiated a slew of preventive measures, the impact of these preventive measures will not be perceived immediately. It cannot be realized immediately. It will have its own time to take. Till then, the number of patients diagnosed with kidney failure, heart failure, liver failure, due to multiple reasons. There are two broad categories of the etiologies for this. For instance, kidney. On the one category, the lifestyle diseases, the hypertension, diabetes, and obesity complex. On the other side, equally formidable and equally important, still not that much recognized, is the impact of climate change, the heat stress, environmental pollution, the chemicals in life, and all these put together, they also pose a formidable challenge. So it's a kind of a double whammy. We are facing both these. That's why the non-communicable diseases, all the non-communicable diseases, including the organ failure, is increasing. So no unnatural death has to happen, and particularly no precious life has to be lost on the road. That should not happen. But as long as it happens, and whenever it happens, the organs should not go wasted. So that kind of sensitization is very important. And 2025, there was one more initiative. We have recently started a students' charter in Madras Medical College, because to catch them young, when the undergraduate students, during their MBBS curriculum itself, we have a plan to sensitize them on all the components of the deceased donor transplant program. They'll be trained and taught about all the components of it, and they can contribute for the program in whatever way feasible and possible without compromising their regular classes and regular learning and so on. There is a huge enthusiasm, and after witnessing the enthusiasm of Madras Medical College students, Transplant is very keen to initiate this kind of a student wing in every medical college, to start with government institutions and then private, and subsequently all the colleges, even arts and science colleges of Tamil Nadu. That is a dream of Transplant. It may take a couple of years to accomplish that. So let me conclude by just showing this slide, and this is one of the donors of 2025, a remote village of Nagapattinam. There is abject poverty. It's just a semblance of house. I can't call it as a house. They don't have the financial resources even to construct a wall. As you can see here, just bricks piled up. The son who was working in a private concern in Chennai, he fell from height. He's a painter. He fell from height and sustained head injury. But the family, very benevolently, with one counseling, they came forward to donate organs. So that is the mindset of the Tamil society. It is up to us, the medical fraternity. There is a very strong political will and very strong bureaucratic support, and the common man is very keen to support. And now I humbly request my own colleagues in the medical fraternity, both medical and paramedical staff, please let us all take a pledge to indulge ourselves, involve ourselves with more commitment in this very sacred program. I often repeat the same sentence, whatever be the role, small or big, if anyone has got a chance to contribute in any way in this program, he or she is really a blessed person. It is a divine will that we are in this program. That's how I perceive this. And this family, I'm happy to share with you, these family members, they received personally honors from the Union Health Minister, Sri Nadu, in Delhi a couple of days ago. Sanjay, you have that photo? The Nagapattinam donor receiving the honors. Yeah. So they felt so happy, and in fact, they were so hesitant to come. They have never come out of the village. Even reaching to Chennai is very difficult. And thanks to my team in Transplant, and we took the family to Delhi. And my humble pranams and tributes to all the departed souls, and great appreciation and pranams to all the family members who very courageously take a decision to donate organs in the most difficult time of their lives. Thank you so much. Thanks a lot. So shall we move on to the next presentation? The topic is Essentials of Hand Transplantation. It is going to be delivered by Dr. Arvind Maharaj. I request the chairpersons, Professor Sukumar. He just recently retired. Thank you, sir, for accepting, and my appreciation to Sukumar, sir. He played an important role in the hand transplant program in Stanley years ago. He just retired from Madras Medical College. And Dr. G.S. Radhakrishnan, HOD, Stanley Medical College. Welcome you, sir. Please conduct the proceedings.
We'll start the proper session. Now I invite Dr. Arvind Maharaj to give the lecture on the essentials of a hand transplant. Of course, hand is not the life-saving, but the quality of life is decided by the hand. So let him start.
Respected chairpersons, Member Secretary Transplant, members of Transplant, senior surgeons, friends, it gives me immense pride and pleasure to stand before my teachers and this august audience to present this very special topic. To start with, hand transplant or appellum transplantation differs from solid organ transplant because it lies under the category of vascularized composite tissue graft. In this world of advanced smart machines and smart processes, only appellum transplant is able to give a patient a fine amount of function and, more importantly, sensation that no processes can give. Most of the people who accept for a hand transplant are in the need or want this sensation more than the function there.
Check.
So how does vascularized composite tissue graft differ from regular? It is a vascularized composite tissue graft is a functional unit that is usually composed of multiple tissue. As in case of hand, you have bones, you have muscles, nerves, tendons, skin and nails. All of this contributing at varied levels to immunogenicity. And as I said, it is essentially a life-enhancing rather than a life-saving procedure. And how many types of vascularized tissue allografts we have? These are types. We have hand, face, anterior abdominal wall, penis, scalp, larynx, trachea and uterus. Of these, hand has been done the maximum number of times, and of these, only the uterus is from a live donor, all others from deceased donors. So why do we need a hand transplant program? when it is not life-saving. We see most of our patients are young males. Most of them are the breadwinners of the family. The loss of both hands causes severe disability and psychological distress and makes them dependent on somebody lifelong. And by giving them a functional and a sensate hand, we bring them back to the society as a functioning member, reduce their lifelong dependency, and do decrease their distress and improve their life self-esteem. So, how are we Indians doing as far as the world is concerned? You can see multiple countries have been doing it. The US have been pioneers in the field, and India right now are catching up, and we are starting to lead. As of today, we've done more than 70 hand transplants, and the numbers are going up with us. So, can you identify the donors in this picture, the recipients in this picture? The picture has a number of senior people who played a very important role in bringing in and starting up and running the program in India, along with two transplanted people who merge well with the normal crowd. So as with every transplant, the hand transplant had taken its principles and basics from solid organ transplants, and we do have multiple stages there. The first stage is preoperative stages, including patient selection, patient education, and organ donor identification, transplantation per se, and the post-op, which includes immunosuppression and rehabilitation, management of post-op sequels, and documentation. So, selection criteria. Age had in the beginning been an important criteria, but it is coming down. We have pediatric transplants being done for congenital abnormalities also nowadays. Bilateral with unilateral is a more of an ethical question, because why would you want to subject a person who's at least partially functional to the problems of immunosuppression? At least a bilateral person who has more severe disparity can be done. But again, the question is a great part with even a number of unilateral transplant. In fact, the first transplant was a unilateral one. The most important criteria here being psychological evaluation. The psychological evaluation is not done at one stage. The patient is usually brought in for multiple consults throughout the stages, where he is brought to understand the needs. The most important being, he should be able to understand or express by himself the reason and the goals why he'd want a transplant. He should understand the added health risk that he is undergone. Being a normal individual, unlike most of the solid organ recipients here, he is almost always a healthy guy who is going to put himself into additional risk of using immunosuppression. He should understand that there can be problems as bad as risk or an organ failure where he might have to have the allograft removed. He must have the financial stability to undergo all these processes. Luckily for us, at least in the post-op period, our government, the Tamil Nadu government, is helping the patients with providing immunosuppression medicines through the government supply. The family and the society should be ready to support them financially and psychologically through this process, and more importantly, he should have an idea about the processes. These patients should have had either used processes or gone through them to understand that they need something better than a process before going in for a hand transplant. So this are some of the pictures of processes. The video displays our first recipient. Again, multiple unilateral amputees who turned up for consultation. The first picture is that of another recipient of ours. So organ donation matching again goes through the same principles that we have. After counseling, the patient is listed. When an organ is called for, the matching happens by ABO compatibility check, cross-matching, tissue cross-matching by CDC, and a HLA component is marked and kept up. Apart from this, the specific things that we look for in a hand transplant are the side, the color, size, and gender. Gender is not a big deal nowadays, and the color and size, if the patient subjects, we do go, even if there might be a slight mismatch. So transplant surgery per se, donor harvest, logistics of transport if it is being done from another center, and grafting onto the recipient. So donor harvest, as with all others, the timing is very crucial. It is done in such a way that the cold ischemia time that we like to maintain here is around 6 hours. So we calculate that, we organize for the transport, flights, chartered or the regular commercial flights, all that have to be arranged. So it is usually obviously under aseptic precaution. We do it with a beating heart. We do it with a tourniquet control. The tourniquet is usually left behind so that there is no bleeding after we amputate. The amputation, mostly a guillotine amputation. We go and remove the limb at a joint above where we are planning to do. For example, if you are going to do the hand, it is at the forearm, and if you are going to do a attachment at the level of the forearm, we go and remove the arm at the level of the arm. It is perfused with the University of Wisconsin solution, packed in ice packs, and is transported. Usually, we do not leave the donor deformed. After the amputation, the hand is usually covered by a prosthesis of an appropriate length. So there is a short video of our harvest for a forearm level replant, where the arm is harvested at the level of the arm. So under tourniquet, it's a proper guillotine. So yes, the arm is osteotomized. It is removed, perfused with the preservation solution while maintained in ice. Perfusion continues usually till all the blood is washed out, and we get a clear flow of the preservative solution at the end of this. After it is washed out, it is double bagged. Unlike solid organs, we do not put it in a slush of ice. It's usually double bagged separately and then placed on an ice box. The box is sealed and it is ready for transport. Logistics, as I explained, we have to time it critically. We have to make sure that the documentations are planned. We talk with the people at the airport and with the airlines so that the boarding, deboarding, and the time spent in the airport is less. Ensuring that the green corridor is approved and enacted by the local traffic. Understand that time is tissue, not just an issue here. So the procedure per se, there is two things that are happening simultaneously when we start the grafting. There is a recipient dissection. Usually what we do, by the time we start our flight, we ask the recipient team to start the dissection here. The dissection is such a way the skin is open, all the structures are separated and are tagged. You can see that there's a white tag that labels each of the separate structures, the tendons, the nerves, the blood vessels, and the muscle groups are done. The donor is brought on a bench which is cold. It is also separated. Usually in a hand or a forearm level, we tend to remove all the muscles, use only the tendon, nerves, and the bone and the skin. Once it is divided and tagged, then the osteosynthesis happens. The attachment is done in the order of bone. If the whole muscle block is preserved, the muscles, then the vessel is attached, the graft is reperfumed, and then we go on to the tendons, nerves, and finally the skin is closed. So here, both the graft and the recipient are brought together. The bone has been attached, and then we are proceeding with the further coaptations and repair. And this is how a final replanted, the transplanted arm appears. In case of two, we usually start out as 4 teams and finish as 2 teams. We have to understand this we have been doing in the form of a replantation for many years together. And now this is essentially for us easier because we have better tissues. We decide on how the tissue is going to behave and use it. So followed by immunosuppression. Immunosuppression is done in 3 phases. Induction, usually with ATG and prednisolone. It is either started the day before, at least an hour before reperfusion of the graft. Maintenance phase, here is typically a tree rug regimen. Tacrolimus, MMF and prednisolone are used always. Since it is a highly immunogenic tissue, the TAC levels are slightly higher than what is normal for solid organs. We try to maintain it between 8 to 12. And antibiotics, antifungals and antiviral seconds for at least 1 year. In case of Rejections, high dose steroid pulses, or in severe cases, ATG is used for management. Complications, as with every procedure, we do have complications, the most common being grafts. Hyperacute reactions are quite rare. The most common are the acute graft rejections. They happen in almost 85% of the patients in the first year, documented globally. And it's quite easy. Since we have skin, they usually appear as multiple rashes that are happening all over the skin. There is warmth, pain associated with the grafts. And sometimes there is stiffness and reduction in the movement that is being found in the graft. It's usually managed with high dose steroids, ATG if needed. Chronic rejections, though not classically manifested or documented, we still believe it is happening. Around 10% of the grafts that have been placed worldwide have been removed over a period of time due to multiple reasons, and pathological examinations on them have revealed pictures very similar to chronic graft rejections in them. Other complications include infections, viral, bacterial, fungal, malignancies like lymphoma, liver, gastric carcinomas have been noted. One of the patients had died because of complications of gastric carcinoma in a study in Norway. Renal dysfunction, renal failures for which transplants have also been done, have been documented. Diabetes and other metabolic syndromes have been noted. Rehabilitation is the cornerstone in a successful hand transplant. The patient's hand rehabilitation starts almost immediately with splinting. Range of motion exercises started around 2 weeks are the first step, which increases stepped up to edema and scar management and strengthening exercises and including activities of daily life to incorporate them into a normal life. Starts by 2 weeks and it's essentially a lifelong process and does not stop. Evaluation, we have multiple systems, scorings and procedure scores and charts to evaluate the function and make sure that the patient is doing appropriate rehabilitative therapies to maintain what he is struggling to do. So how we have been doing in the last 3 years? Our journey started in 2023, just after the COVID scenario. Our first patient was a bilateral amputee, was a post-electrical burn person. Our donor was a 30-year-old female with malignant hypertension with an intracranial bleed. She was from Ahmedabad. Apparently, it has been documented as one of the longest distances where an organ has been transported for the case of a transplant. The team had 8 plastic surgeons, 4 orthopedicians, 4 anesthesiologists, a nephrologist who still takes care of his immunosuppression, 1 vascular surgeon, and 25 paramedics. We took our sweet time. It took almost 16 hours for us to finish the procedure. Went uneventful, and we were left with 2 well-perfused arms. This is the core surgical team with the anesthetist and the paramedics who helped us through the procedure. So this is where he started, where he was at 4 to 5 months. This was in February of 24, almost 8 months after this procedure. This was his marriage in November 24, February 24. He insisted, avanai tali takkattuvan appadinte. This is his latest picture. Especially Transplant has to be thanked immensely for this. We were in between our licenses at that time. So sir called up people here and they very graciously gave us a temporary licensing, took care of all the processing for us and started our journey. A second is a realtor. It was a cracker burst in a funeral. Not only did he have a mangled extremity, which was a hand that was amputated, he also had multiple fractures in both his arms that were plated and also a both bone fracture in the leg. He denied treatment for the both bone fracture, which actually made us lose 2 hands in between because we couldn't get him transplanted with him in the bed. The donor was a 63-year-old male farmer, road traffic accident with head injury. He was from Trichy Medical College. The hand was harvested from Trichy Medical College. This is his post-op. 3 months. He's a very enthusiastic fellow. Fine motor functions still improving. Had his own way of signing papers. So this is where he started. Right now carrying his second child, and he comes to his physiotherapy. He has also made his wife a lawyer. Since he is not the most active person in the family, he made his wife undergo a law course. She is in his final year now, right now. A third is a student who had gone for a part-time job and got his hand caught in a press. A donor was a 19-year-old female from Erode. It was an intracerebral bleed from an aneurysm. Sorry. This is him right now. This was our first unilateral transplant. We were hesitant. She's from Tanjavur, and again from a lower middle class family. Mother is supporting him. But he was very clear in what he wanted. During the course, he was with us for 6 months before we took him. One of the things that we ended up telling him was like, you might end up living 10 years lesser than where you are starting today. But his answer was, I would happily live this 10 years with both my hands instead of that. This was a very similar sentiment to our first patient also. Both these transplants happened within a course of a week. Something not very common, so it was documented in the newspapers in Chennai. Our fourth is the latest, happened in May this year. He was a partial hand, that is his thumb, and he is amputated through the palm. He's from Algeria, he's a 43-year-old gentleman. Our donor was, this time was from Ahmedabad, from the same hospital. We had done a partial hand transplant. We preserved his thumb, fused his wrist, and transplanted 4 of the fingers on the palm from a female again. This is early post-op. Outcomes throughout our journey, we've noted that all the patients, except the last one, had gained protective and discriminatory sensation, enough muscle strength to do most of their works by themselves, and have reported, and we've documented an improvement in their quality of life and function. How is a hand transplant unique compared to other things? Problems, we still have poor awareness. General public, the latest study by a committee that is proposing advancements in and protocols and management of transplant in the US has documented that only around 10 to 18% of the cases who have donated arm in the US and the Europe had a doctor telling them that hands can be donated. Transplant coordinators are getting better knowledge, but there are a few questions that people do ask where they are stumped. At what level the hand will be amputated? Are we going to be left with a deformity with no coverage, or will there be bleeding after that? Are all questions that our transplant coordinator had to come back with us for answers, and we have to educate them better. Poor donor availability, because people think it is disfiguring. The recipient does not want the hand because it is not matching his color or his size. Ethical issues, as I told before, would we really want to subject a normal person to complications on immunosuppression? What happens to the identity protocol? How is his fingerprints going to match? How are the tattoos? As you see, 2 of our patients had tattoos. How are they going to cause any medical issues? Have not been documented so far. One plus is nerve generation. Through the process, we realize that tacrolimus actually enhances the rate at which nerve grows. So usually when it grows at 1 millimeter per day, here we find it growing at 2 to 2.5 millimeters. So they are regaining sensation, and the rates at which they regain sensation is improved grossly. Another problem is the large task force required. We need an in-house team which needs to be bigger than what is needed for other people. There needs to be an intensive planning, intensive training for these people, and proper coordination between the centers that are there inside the hospital and at various levels. Proper recipient selection is very important. The psychological assessment and sometimes physical assessment is the cornerstone. That is the first step. If the first step is done right, we can definitely progress further. An intense post-operative protocol with clear advice that they have to continue it right long is the most important step for the ultimate success of the program. This is how we went about it. The team operating our instrument, the microscopes, the support we had from outside. This is our core team. And this is what I was telling. Even worldwide, the latest study says that most people who have undergone these procedures and lived through the concerns and the complications, they still say they would still go through the experience because of their improved quality of life as a result of the transplant. This and the continued support from Transplant by recognizing us for the last couple of years drives us on to do more. Thank you.
Thank you, Dr. Arvind. Arvind was part of our team at Stanley. So many days we have burnt the midnight oil and done a lot of replants. Happy to chair the session, but there are a few points which we have to note. As he said, it is totally a non-critical replant. When it comes to a non-critical replant, you have to analyze yourself critically, and also you have to give a proper critical counseling to the patient as well as to the attenders. It's very important. And second thing is, as we all know, the tacrolimus, other things, they improve. There are certain studies which have told like that. But still, intrinsic recovery we'll have to take care. Unless we take the intrinsic recovery, which is going to be a fine motor recovery, and it's going to be very useful. And there are certain patients, last 2 weeks back also we counseled a patient, 2-3 weeks back I think, I had counseled a young boy who had come. And then we had to tell them both the pros and cons and other things, everything. And he preferred, because he is oddly from the school, so he preferred something different, not for the hand. So we have to respect the opinion of the patient, donor and families, and we have to maintain the privacy of the donor and family. It's always better. And rigorous postoperative physiotherapy is very important as that of the surgery in hand transplantation, like in hand replantation. Now I hand over the mic to Dr. Sukumar, who was part of the first hand transplant which was done in Tamil Nadu.
Actually, as Dr. Arvind told, it is not a life-saving, but the quality of life is decides, because there are many school of thoughts among the plastic surgeons, the hand surgeons, whether the hand transplant to be done or not, because there is pros and cons, because it is only concerned with the quality of life, because there is no life-threatening any problem. So they have to be, the patient has to be, as Arvind told, the patient's concern is very important. So I was also, I was the first, part of the first hand transplant in the government sector in the Tamil Nadu. So first time we have done that, it went on for 13 hours. The patient was very consistent that he wants the hand transplant to be done. Previous, some 3 months before, we have attempted one time. I was that time on the duty and I have counseled about 10 persons, but they have, everybody have refused. But this person is very consistent, he wants hand transplant to be done. I was not for or against, but I was neutral. So he was the selection of the patient was correct. So he was very adamant that he wants the hand transplant. As Arvind told, even a Markandeyan Mari, நான் 16 வயசு இருந்தாலும் பரவாயில்ல, நான் வந்து quality of life ஓட வாழலாம் அப்படின்ட்டு அவன் decide பண்ணிட்டான். So it is, we have done the hand transplant, but till now he is living, as Arvind told, it is the first hand transplant, only hand transplant till now. After that we have not done anything in the government side. The patient also has married and he has got 2 children. His face, the smile in his face itself is changed. So I have seen that he still is in my follow-up. The only thing I want to tell is, see, there are various transplants, the kidney, liver, heart transplant, everything. But this is a non-critical and one. So we have to study what is the amount of the immunosuppressions in the critical transplant, and here how much it is they are getting, and what is the comparison, what is the complication, is it really alarming or not? Everything should be studied, and how the functional recovery also, because all the hand transplants patients will be very happy because previously they didn't have any hand, they have the hand. So that itself will give you the boost. But from the scientific point of view, from the medical point of view, we have to see how the functional recovery, how the actually the critical intrinsic, as Dr. Radhakrishnan told, the intrinsic recovery, everything we have to study. As a transplant authority of this nodal organ, so I requested Dr. Gopalakrishnan to make it a hand transplant study. In worldwide also, it is only done very few cases. We have to study in worldwide and also in India also. We have to study what is the cost of the transplant, how it has been done, and the immunosuppression, what is the complication rate, actual complication rate, everything we have to study, and we have to put up a paper. I request this Transplant should take that initiative. Thank you.
Actually, I tried, one case where there is total amputation penis. I couldn't counsel the patient. Patient was around 50 years only, but I couldn't counsel. First counseling itself, he refused. So we had no choice. He was very comfortable with the perineal urethrostomy and other things, post-CA penis. But I think we can also try that. Compared to other this thing, probably it may also be a little more productive. Thank you very much.
Thank you, sir.
Any questions from the floor? Any questions from the floor? Okay. Okay, thank you so much. That was a very nice summary of hand transplant. As I agree with the chairpersons that the patient's acceptance and complete understanding of what is hand transplant all about, that is very important. And I think every hand transplant team is very careful in choosing the donor, choosing the recipient. After explaining all the complications and the necessity of lifelong immunosuppression and the attendant complications and the cost factor involved and all those things. But in spite of all that, I'm sure that many fit and willing recipients. And I'm reiterating for the sake of the transplant coordinators, there are some myths about asking for hand donation. Myth number one more organ. So one more organ that will prolong the time. Please don't be under the impression it is not going to consume extra time, because the arm can be extended and simultaneously a hand can be retrieved without any extra time. That's number one. And number two, another impression is that there can be a profound blood loss, and already a precariously balanced recipient may go in for hypotension and all that. As it has been demonstrated as a guillotine, and I think blood loss is least. That is a second thing. Am I right? Yeah.
Yes, sir.
So, and third thing is that from the donor's family, they may think that there will be terrific disfigurement of the donor's the mortal remains, and please assure them that appropriate suitable processes will be placed, and it will not be evident at all. If you just look at the mortal remains, actually it will not be, the disfigurement will not be there. These are the three major concerns from the field. People represent these, and wherever there is a feasibility, please keep asking for hand also. Thank you. Thank you so much, sir. Thanks for the persons.
If I may, sir, one question, sir.
Yeah, please.
Excellent presentation. This is the second time we are seeing it. First time Patmava, it was very touching. But you left a video which you played, the recipient who comes back. Unnecessarily, that had the greatest impact. If I recall, you had the hand recipient patient, I think a mother. Am I correct?
Yes, that is the long
I
video.
recall that was a very touching video. I was waiting for that. But excellent work. ஒரே ஒரு doubt எனக்கு.
சொல்லுங்க.
Arterial line போடுவோம் இல்லையா
Yes,
sir?
ma'am. Yeah.
So what happens to the arterial line?
Usually, if it is done on that day, we can remove it, nothing will happen.
Nothing will happen.
One.
So,
So if
ideally, the ideal time to do the hand transplant, the guillotine should be after the heart is out.
no, ma'am, before that, we want the organ perfusing when we are going to go ahead with it.
Cardiothoracic people will not accept. They will want the arterial IDP. So how do I manage between the cardiothoracic surgeon and
Madam, I'll answer your question. See, always, Dr. Gomati,
Chairperson wants to answer.
femoral artery, urologists came. They are not happy about the femoral artery.
Ma'am, the last one had a multi-organ. They had gone ahead with a line on the leg, in the leg, the last one. So we had a good coordinator there. The plastic surgeon was taking care of things for us. So the line, the BP line, the artery line was in the leg. There was a hand line. In this case, the line had been placed 3 days before. And when we brought in, we were not too happy with the artery, the radial artery. So what we did was we cut off that offending segment and reanastomosis at that level. And for BP monitoring, that patient had a line in the leg which was taking care of the issues there.
I mean, the surgeons, once they open the pericardium, they'll directly put a small cannula or needle in that, you can directly measure the pressure from there. By the time, even if you use radial, we don't have femoral, doesn't matter. So surgeons can just help us with putting a needle and measuring the pressure.
and not only that, in the technicality of the hand transplantation, when the heart is on, if you remove the hand, when the heart is on, when we do the guillotine, the intrinsics and other activity will be much better. It can be better because the perfusion would be much better.
Small muscles have
Small muscles action also can be facilitated. That's one of the small tip which we use.
Thank you so much. So
Thank
we
you.
need a lot of learning here. Thank you.
Thank you.
A token of appreciation, please receive this.
Excuse me, sir. Sorry, sir. Sorry to interrupt. What happens to the biometrics of the patients, Aadhaar and everything? We have to re-register.
That is that was what I was telling. We do not have clear-cut guidelines as to what is happening with the ID. The fingerprints, the tattoos. Sometimes the tattoos are also used. I told you, 2 of my patients have tattoos there. Still working on it.
No, that is already in the government, there is guidelines.
Iris can be taken.
Guidelines.
Iris can be taken.
We have to everything, that is the thing. We have to certify. Sir, even in transgender, we are doing lot of surgeries. We are again recertifying. That's all.
Thank you, sir.
Let's move on to the second talk. Liver transplant may. Okay. I request Professor Sukumar, Professor and Head, Surgical Gastroenterology, Madras Medical College, Rajiv Gandhi Government Hospital, and Dr. Gomati Narasimhan, Dr. Rela Institute and Medical Center, Chennai. Thank you. Please take over the podium.
morning to one and all. It's my privilege to introduce Yelango Saidu. He's one of my good friend, and he's right now he's working in he's working from multi-organ transplant surgery center from Royal Royal Care, sorry. Because he recently moved to Royal Care Hospital, and he is qualified from Madras Medical College from MCH Surgical Gastroenterology in 2010 and 2010, and he did his fellowship in Pittsburgh and 2014 to 2016, and he did his fellowship in Tokyo recently in 2024, pediatric transplant fellowship. And he has got a vision in doing a pediatric transplant. That's how he has done recently in 2024. And he has done many, worked in many places in transplant surgery all over the city, like Miyot Hospital, Fortis Malar, Kaveri Hospital, and CSI Kalyani Mission Hospital. Many places he has worked, and he has worked in many centers, and he has got he has trained many surgeons who has worked under him, and he is a fellow who has trained many surgeons under him, and he is a member of American College of Surgeons. He is a member of Indian Association of Surgical Gastroenterology, and he is a member of Association of Surgeons of India, and is a life member of Liver Transplant Society of India, and is a life member of Indian Society of Surgical Oncology. To add to his this thing, he has got many presentations in his this thing, and he has made many presentations in national forum, and he has made many research publications in his name. So over to you, Yelango. Today we like to hear from you on what you are going to do on liver transplantation, what we need to know from you. Is everything right, Yelango?
Getting the presentation on, just give us a couple of minutes.
Yeah, he has got many interest in Japan to get trained himself, because we transplant surgeons routinely get ourselves trained frequently, go abroad, get trained ourselves even at this age. You'll be around 40 to 45? Actually, you're very kind. 52. So we are waiting for the slides to be loaded. He's a good teacher. He goes on teaching everybody. You have anything to add on, madam?
Now, in his WhatsApp status, now almost every day he puts some key message about liver transplant for the common man. Those who are not following his status, please do that.
Thank you.
Very cryptic, essential information about liver transplant every day. There'll be some message in his WhatsApp.
Yeah. Over to you. You can now have your liver transplantation. What we all need to know from you.
Thank you, sir. Thank you for the kind words. Sukumar sir was my senior in MCH GI surgery. He has been a friend for a long time. It's nice to have. And Gomati also was a forerunner for liver transplantation at the ASTS. I interviewed at the same place in Dallas where she trained. So it's nice to have them. And thank you for the opportunity. Professor NGK was kind enough to give me this opportunity to share the dais in this August audience. I wanted to keep the topic very light today. Liver transplantation has been practiced quite well in this region for more than 15 years now. So a lot of us are quite familiar with it. So I wanted to keep it light and pass on the information about the challenges that we may be facing, we are facing now, and then in the future as well. So to start with, one of my favorite quotations is from George Santayana's, "Those who cannot remember the past are condemned to repeat it." I trained in the Starzl Transplant Institute, so a lot of things I learned from the memory in that institution, which helped me frame my own protocols well. So this is Professor Hiroshi Sugawa, who trained me, who is a multivisceral transplant surgeon. So this was during one of the donor runs. He was very keen on taking a photograph, and you should see that I'm the shortest of them all. So I'm looking at the pilot, who was actually scolding me for delaying the flight. And he said there is an upcoming storm, and the next 1 hour back to Pittsburgh was a very unforgettable and painful experience of going through a turbulent flight in a Learjet. And we always used to get, when we were fellows, we used to get biscuits, cookies on our fellows' room from some unknown person. After 6 months, we actually found out that it was one of the coordinators who was actually giving us those gifts. When we asked her why she was doing it for us, she said, "Do you know that your job is one of the riskiest jobs in surgery?" And then she sent these 2 papers and some references as well. It is truly considered, transplant surgery and organ procurement is considered the riskiest job in surgery at that point. So how did I end up from being a HPB surgeon, which is a very stable, comforting job, to a transplant surgeon? I wanted to look through what actually interested me. This is Professor Stuart Welch, who performed the first auxiliary liver transplantation in dogs. The liver was considered a very mysterious organ. There was lots of questions from ancient times regarding the dual blood supply on the inflow side, and whether the liver is dependent on portal blood flow or the hepatic artery oxygenated blood flow. And there are still questions on what actually impacts the outflow of blood from the liver. So when Stuart Welch did the first auxiliary transplantation, they found out that the liver rapidly atrophied. So this was published in a very small paper, and after that publication, Starzl took this up and discussed with him that there is some component, unidentified component in the portal flow that is responsible for keeping the liver in good function. So his experimentation, as per his own biography, Puzzle People, is about developing this in the dog transplant. These were the 2 technical procedures developed by Dr. Starzl. He started his work in the Johns Hopkins and then moved on to Colorado, and he continued to do these things. 2 technical procedures were the one en bloc multivisceral, which is on the right side. The right side picture is about the multivisceral block, which has the liver, intestine, spleen, pancreas as well, and liver alone. So those 2 technical procedures were developed by Starzl. And since we know that the auxiliary placement of a graft does not work very well, they developed the orthotopic, removing the whole liver and then going forward. There were 2 further challenges. When the liver comes out of the body, how long can we preserve it? So they were initially using Ringer's lactate, cold Ringer's lactate, to preserve the liver. It was a short time in the dogs. So that was the beginning of the perfusion solution story. We have come very far from that. The second one is, how do you handle the unhepatic phase and the hemodynamic changes? So they invented the veno-venous bypass, where the blood from the lower part of the body is taken through an extracorporeal route right back into the heart through the superior vena cava. So in the year 1963, Thomas Starzl performed the first liver transplantation, which unfortunately was not successful. The first successful transplantation was in the year 1967. The year is a little strange. This was just 1 year when my father was a year one medical student at that time, and this man performed the first liver transplant in the world. He's an amazing personality, Tom Starzl, and built a great team. This was in the 80s where they were doing the transplantation. This is from the University of Pittsburgh. You see the crowded activity within the operating room. Starzl is well known to walk inside the operating room at any time and inside the hospital at odd hours in the morning. On the left is Professor Carl Groth, his first fellow in liver transplantation. Carl Groth is with the first set of pediatric liver transplantations done at the Children's Hospital in Pittsburgh. You can see all the Cushingoid faces in the children. Carl Groth's last PhD fellow was my assistant professor during training. These two together put together a motley crew of surgeons from Spain, India, Japan, China, and few white Americans as well. And they built the transplant program. It was a difficult time, and they made up all the discoveries and the developments as they went along. Across the Atlantic, there was another great man, Roy Kalne, who developed liver transplantation. He was with one of my favorite professors, Harold Ellis, and then went on to build the Cambridge program. And these two were very, very good friends, and they kept close communication with each other to develop. I was fortunate to be one of the last few people to actually work with Professor Starzl in the STI at Pittsburgh. He passed away a few years after I left the program. Now, fast forward to the year 2025. Around the globe, we perform about 40,000 liver transplantations. It is no longer an experimental procedure. It has become extremely standardized. And in India, we perform about 4,000 liver transplantations annually. So we saw this. So there are a few questions and challenges which we have. The burden and the need for liver transplantation still remains high. About only 10% of the liver transplant candidates actually receive an organ. This is across the globe. The 3 countries which perform the largest volume of liver transplantations are USA, China, and it was Brazil, but I think India has, Professor Samdhiranandi recently published in 2025 that India has taken over the 3rd position for the largest volume of liver transplants in the world. In India, we have about 183 centers performing liver transplantation. But overall, the ethical challenges across the globe still remain. We still need to define, there are challenges in defining a deceased donor in many countries across the globe, and there is a constant fear for exploitation of living donors in living donor programs in the East. Professor Nandi published the statistics in 2009 when Professor Sugmar just finished MCH and I was second year. India performed about 450 transplantations, and then now it's close to 4,000 liver transplantation. We have exponentially grown in volume and experience. If you look at the number of centers in Tamil Nadu is actually very high. We have about 42 centers. But apart from Delhi NCR, most of the transplant activity happens in the southern part of India. There are new programs which have come up. I've just marked them. And surprisingly, we have 20% alcoholics, 20% of NASH, viral diseases causing liver transplantation, and cryptogenic cirrhosis, again another 10%. These constitute the vast majority of the transplants that happen in this country. And we have a good pediatric transplant volume
in the world, but still the volumes are less, and many of the children actually fall out of the wait list while they are waiting for a liver transplantation. So currently there are many challenges. I just looked on this. In clinical practice, we still have challenges in referral triggers. So the guideline awareness even across the globe is very, very less, and the number of patients who get referred for liver transplantation at the appropriate time, either by biochemical criteria like MELD scores or in non-MELD criteria like the decompensation clinical parameters, is just close to 30%. That means 60% of the patients who require liver transplantation still are not referred at the appropriate time for liver transplantation, even across the globe. It's not just in India. The physicians or gastroenterologists who manage liver disease still want to look for one more lab even when the patient has crossed the transplant referral threshold. There are huge health system gaps. So when patient wants to go from center to center or from city to city to get the transplantation, we still have great difficulty. Even in Tamil Nadu, there is a lot of gap in the transplant center south of Madurai. Those are challenges to be met. We recently had one patient which we had to refer to Bangalore because he worked for the army. But he delayed by a week, had a major bleed, and then lost his life. So such tragic stories are still happening despite all the volumes that we do, and that actually should encourage us to actually pursue a liver disease is still higher. The inborn errors of metabolism identification at the initial treatment is very, very poor. We still don't have IV sodium benzoate, which can salvage patients, babies with hyperammonemia. Most of the children with hyperammonemia are treated as TAM and then given oral sodium benzoate, which never has an effect. We don't have the essential skills for developing pediatric plasma exchanges and CRRTs, which is very limited to few centers in India. So there are real big challenges that we still have. Donors, obviously, there are multiple varieties of donors that can contribute to liver transplantation. The most standard one is the brain-dead donor, which we are all aware. We are the largest, we have the largest number of brain-dead donations in the country. And we still don't have a well-formulated rule for circulatory death, but we are taking steps for that. India has become a live donor program essentially driven by North Indian states. The living donors meet most of our donor requirement needs here. There are a few centers who are trained in split liver transplantation, and domino transplantation is also being explored. So these are the options where we can get a good liver source. So I have just highlighted that these are the things. The brain dead is the standard, living donors and split liver transplantations happen. Dominos are few, and DCD livers are also few, especially only with controlled DCDs in a few centers in North India. These challenges are, we understand that there are huge regional variations in organ donor acceptance. And recently when we interact with ICU physicians and neurologists, we find that the hesitancy among healthcare providers still exists. And many ICUs delay and avoid brain death certifications even when they meet clinical criteria. Even when I was sitting here, we were discussing with one such situation in our place. There is still a fear of family backlash, even in large donor areas like the West Zone in Tamil Nadu, where individual physicians actually fear of family backlash. Neurology providers feel that brain death declaration as an admission of therapeutic failure. So that kind of penetration is still not there. And I always raise this question that the brain death has been defined only with relation to organ donation in India and not with the other legal issues. Media scrutiny also has a fear. We used to have donor champions in every organization in US, but still there are nothing. I was so happy to see the student initiative taken by NGK sir on this. The newer developments in organ preservation relate to the mitochondria. A surgeon actually, I was a very poor biochemistry student. I barely passed the examination. But after becoming a GI surgeon and transplant surgeon, I had to go back and read most of the biochemistry to manage pediatric liver diseases. And this got my interest. This is the mitochondrial respiratory chain. The mitochondrial respiratory chain has a very key role in generating the necessary ATP that preserves the cellular membrane function. As long as that happens, organs do very well. So there is a very renewed interest about 15 years ago, coming mainly from Switzerland, Professor Dutkowski. They are very interesting. So they developed something called the hypothermic oxygenated perfusion machine, which came to India about 3-4 years ago, right at the end of COVID. And we have used it. It resuscitates the mitochondrial respiratory chain to provide more stable grafts, which actually function very well after liver transplantation. We also have the normothermic machine perfusion, which is also, despite the expensive costs, a few of us have used. The third challenge is in providing a very streamlined liver transplant evaluation after triggering the correct point at which the patient has to be referred for liver transplantation. So essentially this consists of a few things. Is the patient the right candidate? Is this the right therapeutic window? Does the patient have contraindications? We also look for how the other non-hepatic functions. For example, even when we put in a good liver, we expect preload to increase during transplantation. So the ejection fraction, we have a cutoff of about 50, but an EF of more than 40 is mandatory for doing liver transplantation. And the pressures on the right side of the heart also dictate how much we can take. And the newer developments in pulmonary hypertension management have not percolated to India yet. So all those things have to be evaluated. The etiology has to look for the risk of recurrence. There is a screening for malignancy because we use immunosuppression. The technical feasibility of surgery has to be evaluated along with psychosocial and adherence assessment. We have seen patients who go back to alcohol, go back to drug abuse, especially when they come back from North India. And we have been saddened to see that that's a process over which we have no control. And again, social and financial support, which the government has started providing us for many years in liver transplantation. So my key considerations in performing a liver transplant looks at these parameters, which is not purely technical. It's the cold time, which has to be restricted to less than 8 hours. In Tamil Nadu, we try to keep it less than 6 hours. But with mesh and perfusion, we are able to extend it a little further. The warm ischemic time is technically how you do the liver transplantation. It should be restricted less than 60 minutes for optimal graft function. For the size of the liver has to be matched. Small recipients require appropriate size donors or suitable reduction of the graft. The two essential ones, vascular-wise, is an unhindered outflow and an adequate portal inflow, which is regulated. I think we can skip that. For the, let's skip all this. I didn't want to go into too much of technique actually. So in DDLT, we can preserve the cava or take out the cava and do a caval replacement technique, which is the oldest technique developed by Starzl. And then Dr. Sakis developed the PE back in 1983. So developing a transplant program requires how the flow of care actually happens. I've just shared the DDLT 101 notes, which we have been using for almost 9 years now, the hepatocaval anastomosis algorithm. We have not faced these situations in the US, so we always look for unsafe clamps, unsafe assistance, which is very common in our place. And if it is there, we go with the preservation, side-to-side ostomy. That is pretty much the go-to procedure in our program. And if you have any difficulty in common cloaca creation, when you have even safe clamps, we still prefer to do a side-to-side cavo-caval anastomosis. And the classical piggyback is very much restricted in our program. These are the technical developments that have happened since the time liver transplant became a standard program. The first one was the piggyback IVC preservation by Professor Sakis. The second one was the APOLT, which was developed by Pickelmeyer. The dual living graft was developed by Sangyu Lee. And then the laparoscopy era was started by Professor Oliver Sobrain in 2002, and now it has become standardized, and now today we have robotic, and Professor Rela has completed the robotic implantation as well here in Chennai. So, and then from 2016 we have the normothermic perfusion, and 18 we have vascular assessment using ICG fluorescence. We are also very, very happy to see the development of critical care in India, which actually is the challenge in building new liver transplant programs in the state. IC protocols have really improved outcomes. They have early extubation now, fast-track ICU pathways, and enhanced recovery bundles. We have widespread use of TEG and ROTEM now. The newer ones can be transported anywhere. We have goal-directed fluid therapy and a lot of blocks and local therapies. So looking back, we have standardized the surgical technique in diseased donor and living donor transplantation. We have addressed all the variants, the technical variants in outflows, more complex portal inflows where the portal vein is occluded. We have we are able to do surgeries on much smaller hepatic arteries now, and our biliary anastomosis has become better. In fact, Dr. Vivek Vijay's technique is widely adapted by many surgeons across the globe. We have also become better in donor management and organ preservation. We have better static cold preservation. We have rediscovered, one of Stars's old photograph had ringer lactate circulated by a machine. So we are rediscovering dynamic preservation now. With normothermic perfusion, we have eliminated temperature as a key in organ preservation to hold down the sodium potassium ATPase. We have a better understanding of the mitochondrial respiratory chain and Krebs cycle within the transplant milieu. In immunosuppression, I think you had just heard about the immunosuppression, so I didn't want to go through it again. We have better management of medications now. There was a time when I came here, when I used to go to Trichy, people did not have tacrolimus values assessed and reports given on the same day. So now we have widespread use, and transplant patients come from different cities. They are able to get their tacrolimus done locally. There is better management, that has led to a better management of the narrow therapeutic window. Costing is also better addressed. We are able to get insurance from the government as well. And we have now getting better diagnostics on rejection as well. Liver biopsy interpretation has become quite standard in many, many programs, and we have people like Mukul Vij who can help out newer programs to set up their own liver pathologies. The surprising thing is the development of infectious diseases is a good program in liver transplant units. They have improving diagnostics. Sometimes we get infection results within 6 hours. But the challenge of multi-drug resistant organisms is very much there, and some of them are donor-derived infections as well. There is a large resurgence in fungal infections after COVID. I think those are coming up things, but PJP still remains rare. We're also very, very happy that liver transplant benefited from good critical care across the country, from very great paratransplant activity. The microbiology and infectious diseases specialists have become very, very good. We are able to get such services from almost all the hospitals. We're also very, very happy to see better engineering and people interested in developing. So I interact with young engineers who work on artificial intelligence, and we run our own Python programs. So we are very, very happy to see better engineering solutions to both mechanical and this digital devices as well. We are seeing better nursing management and rehabilitation across many hospitals in the country. I think they are all good for transplantation. When I came back from the US, I used to feel that these were great deficiencies. Even though my concluding slide has so many key takeaways, but I think this is one journey where we want to go very far. What I dreamt was to see transplant go the way of CABG, where a patient with a liver failure or a HCC can get an organ within a month and go on to have a second chance in life. And for that very far journey, I think we can all go together. Thank you.
Hi, Dr. Ilango. Thank you for the talk. Before I open it up to the floor, couple of things from your last slide, I'm going to go back. So, how do we bridge this gap? You mentioned a lot about late referrals. Now the transplant has been happening even in Tamil Nadu, from 2007 and in the country for a bit longer, liver transplant. What is it that we as liver transplant community should do to change this situation? And second thing, you mentioned that everybody should try and get an organ early. Now, from the numbers that Professor NGK mentioned, there were about 60 livers which were not used last year. Again, what are we going to do about it?
So with the first question, that's a very difficult one. This is a complex scenario. There is no penalty for mismanagement of a patient in our country. I don't think so. It's there in any other country as well. So the way counseling is done is that liver transplantation is the last resort. So when people take it as the last resort, when a senior doctor tells them it's the last resort, people really put it as the last. So the only way we felt was not to challenge the primary providers, but to encourage, educate, and provide better outcomes. So that really takes time. I had the opportunity to talk to a few people. You trained with Dr. Goran Klintmall. So during my interview, I asked him, what exactly was the challenge when you actually came to Dallas? So he said, they invited me to come to Dallas to start the transplant program, so I did not have anybody challenging me. I have put the same question to Professor Kasahara, and he said when he joined NCCHD, they would not even refer a pediatric transplant patient to him. So those challenges were faced by those pioneers 15 years ago. I think India is a vast country and we have still not penetrated. I just came back from Northeast India. I've seen about 40 odd patients with alcoholic liver disease, at least 15 of them require liver transplantation. They don't want to leave Northeast India to come down south to have a transplant, despite counseling them. So even the primary physicians have great difficulty in convincing people. We should still communicate, educate, and keep the lines open. I think it will get corrected over time. It's a very short time for things to develop.
Sir, were you going to say something? Okay.
The second question is graft wastage. See, India, I mean, we have to look into those data deeply. I appreciate Sir and Transplant's efforts to collect data from everything. It is that data which will give us solutions for the future. We don't know why those grafts were rejected. So at that time, there may be logistic issues, there may be graft. We actually have found out problems in the graft maintenance, everything we can look into.
If I may rephrase, sorry to interrupt. What I was trying to arrive at is I'm not specifically on those 60, but I think in forums like this, we need to take home some point for each of our specialty. And maybe we should all, the liver transplant community of Tamil Nadu, look into those numbers to see how we can get better. I think at every year, if we can get some learning point out of the previous year, we will get better is what I feel.
I agree, I agree.
Yes, sir.
Yeah, I have something to say actually. For your kind information, those livers which were not utilized, I think hardly any instance it was due to logistics or unwillingness to donate. Most of the livers that were not utilized is based on the liver biopsy finding.
Yeah.
Very disturbing development nowadays is that very high rate of asymptomatic steatohepatosis. Even non-alcoholic, the fatty liver. So that incidence is pretty high, and that precludes utilization of liver.
That's going to be a problem, sir, because general prevalence of NASH has increased so much. So in the years to come, I think that is going to be a big problem.
And due to logistics and due to kind of unwillingness, non-retrieving liver is, it has become a very, very rare instance, unlike in the past.
Agreed.
Thanks to all the transplant coordinators and the the disease donor maintenance teams across the state of Tamil Nadu. Sometimes, the liver team has to be rushed to the spot from a totally different place and so on. There are many instances, a lot of heartburns because, that prolongs the entire process and so on. Like our team bears the brunt of the attack from all sides, and we act as a buffer between the different teams, and somehow things are happening. And also there are some local arrangements, like, sometimes, the team which is available locally, they are kind enough to retrieve the organ for that team which is going to utilize, and that kind of the friendship is increasing among centers as well. So logistic reasons, non-retrieval of, non-utilization of liver is almost reduced very much.
Sir, should we finish or do we have time for question from the floor?
Maybe a couple of questions if... Okay, fine.
Dr. Swaminathan? Yes.
Thanks for Elango to making us travel through the history of transplantation. Elango, sir? Thank you for making us travel us through transplantations. So I have a few questions, sir. Hypothermic oxygenation is it still required for us, necessities there in the practice?
See,
before sir is going to ask you something.
It's not mandatory. As long, see, what I see is the moment you cross clamp, the organ, the mitochondrial respiratory chain literally stops. So there is no ATP generation. So if the liver has got a good ATP reserve, I feel it will survive the reperfusion well. Okay. So a hypothermic oxygenated perfusion will provide oxygenation during the preservation time. Because as the solution goes colder, oxygen dissolves and there is no need for any vehicle like hemoglobin to take the oxygen. So when you drop the temperature lower, oxygen can mix in any fluid. So that way we are able to provide, it's much more easier.
I just want to know, in future, in a state-of-art hospital, hypothermic perfusion should be there or not?
It will be there.
It
will be there.
Yes, sir.
Yeah. The number, Dr. Gomati, the number you mentioned, 60 out of 268 donors, is a significant number. That's almost like we're talking about 30-40% of the livers being discarded. Even in a system with a DCD, the discard rates of liver is significantly lower than what we are doing now. We need to really look into it because, as Professor NGK said, it may be lower from logistic reasons. Actually, we are looking into the data with the Video Lab to see what's happened in the last 3-4 years, 2-3 years about the what are the reasons for discard of livers, because last year has seen the largest number of liver discard rates, so which is very high, where we are already looking at a dearth of donors. So Again, we will come up with the data, which is obviously the video lab has got all the data. I can tell that yes, still there is a number which we can avoid, like the logistics and the subjective finding of this liver is not usable, last minute decline, all those things can be avoided if we have certain protocol in place to decide this is how we're going to decline the liver.
Yeah, that's quite promising. Thank you. Thank you very much, Dr. Elango.
Let's move on to the next session. The optimal management of a brain-dead organ donor, targeting maximum organ utilization. I invite Dr. Murali Krishna. He's from MGM Healthcare, Chennai. I request Professor Dr. Sundar, Kaveri Hospital, Chennai, and Dr. Govini from Gleneagles Health City. Please take over the podium and conduct the proceedings.
Good morning, everybody. Dr. Murali Krishna needs no introduction. He's been in the transplant for many decades now, and we're all eagerly waiting to hear what he has to say about management of brain-dead donor.
Very good morning, everyone. My sincere thanks to Transplant for giving me this opportunity, and thank you, chairpersons. For the next 30 minutes, I'll be talking about the care and maintenance of a brain-dead organ donor. This is with the target that we will be able to use the maximum number of organs, and this is mainly focused or based for the team which will manage the donor. It's not for the teams which will harvest, but more for the teams which will manage the donor there. To start with, this is a paper. Whatever the outcome of this, what this shows is like when they try to study the outcome of the donor hearts long from the time they were transplanted, that is 5 years, 10 years. So just put it simply, this is the impact that a donor management has. It's not just on the day the organ is utilized. The impact can be there even 5 years, 10 years survival of the recipient post-transplant on how we manage the donor. Also, as we all know that the number of transplants that are dependent upon the deceased donor, especially the heart, lung, or the deceased livers, is capped. It's capped since last many years across the world, primarily because of the availability of the donors there. Along with that, as you see in the table below, the number of organs that are utilized are not full. Even for the heart and lungs, that comes barely 30 to 40% of the organs being utilized. So putting all this together in a simpler way, this is what it is. There's always a high waitlist mortality for all the patients who are waiting for the organ. The donor availability is a very major limiting factor for all of them. And there is still a significant scope for increasing the organ utilization rate. And what the care we give for the donor not just lasts on the day of the harvesting, but it has a very lasting impact on the survival of the recipient there. With this, let us go into how do we manage a organ donor there. This has a lot of unique challenges to start with. The patients are the one who has a poor neurological outcome to start with, may not have received the attention primarily because of the poor outcomes which they have even when they presented to the hospital. From that point, this case becomes something that's a very important case or a very focused case once the patient becomes an organ donor. Along with that, this is the only patient where we go for an organ-specific care. We know that at the end of all this, the patient is going to be no more, but you are more looking at keeping the organs usable in this. Then obviously a lot of teams comes there with different viewpoints, and along with that, a lot of coordination and communication for the team which handles the donor. So this makes it very unique when compared to any other patient who is present in the ICU there. So if we look into the care of the organ donor, always the target is to get the maximum organs out of that. That we can broadly divide the talk today into how do we manage the general ICU care and how do we go for a specific organ care. To go for the general ICU care, the hemodynamics, if we look at, it's always a must to have the invasive pressure monitoring. The invasive pressure monitoring is not just the arterial line, but have a central venous line and get the central venous pressure transfused, because that has an impact on the organ protection and survival there. The standard targets, targeting around 70 to 90 mean arterial pressure and having a CP of 5 to 8 is important. Very important in all of them is to have a good stable cardiac output. That can be simply bedside assessment can be a very good peripheral pulse, having a good tissue perfusion and serial blood gases showing a normal lactates. And vasopressors as a reads or a need for maintaining the blood pressure should only be considered only once we achieve the targeted fluid therapy. That is very important in these patients. And all donors, since they have the brain dead pathophysiology, they need a hormone resuscitation requiring replacement of steroid, thyroid, vasopressin, and insulin. Different protocols are there across the institutions, but all of them should get this. Then another challenge that comes in the donor is the management of the sodium levels. All of them do have hypernatremia there. The primary stay is by restricting the sodium containing fluids or sodium containing drugs, and then resuscitate with a half NS or a dextrose solution and to go for a hormone replacement in these patients. Equally important, which has an impact, is the infection control. We do see that a lot of them do have wounds because of the trauma, which can possibly get infected, leading to sepsis. So apart from this, a very strict hand wash and hand hygiene, taking care of all the bundles in the ICU, the urinary bundle, the CVP bundle, the ventilator bundle, all this is extremely important in these patients to prevent the infection in these cases. From the infection perspective, all these patients do undergo a serology and a surveillance blood cultures. This is to see and alert the teams accordingly. But if a donor has a positive blood culture or a positive sepsis, that doesn't mean it's an absolute contraindication for organ donation. It depends upon the clinical scenario. Some of the organs can still be utilized in a patient who had a sepsis there. So with this basic idea about the general care of these patients in the ICU, let us look into the organ-specific care or further how do we do the donor management. So the teams which are managing the donor, they need to know the certain criteria pertaining to every organ. One, what are the accepting and declining criteria for the individual organ? When do you call an organ a borderline organ? That comes in between. And what are the ways to optimize this organ? So this helps them in many ways. Like to start with, you can have a quick look at what are the organs which are usable in this particular donor. In the first look itself, which can be usable, which cannot be usable. And then titrate your care based upon this to make the maximum out of the organ donation. Then helps you in coordinating with the different teams with a very specific focus on how to manage these particular organs. And the current way that is being followed is, it's the way world going on. Initially, when the donations were started, a lot of times the teams used to go and manage the donor, a cardiac team, liver team, with different thoughts. But currently, it is one central intensive care team of the donor hospital which manages this patient. And this is the way that is to move forward. One team will take care of all the organs there. So what is the main advantage for this? Again, the time available. A lot of times, especially when we have the borderline organs, the time available for resuscitating the organ and making the organ usable is much shorter for the primary teams that come for organ harvesting. So the team which is managing the donor will have a much longer time to make these organs which are borderline to become usable organs there. So let us, along with that, it's equally important when we say a particular organ is not usable, that like anything else in the medicine, we have all this contraindication as both absolute and relative there. So it has to be decided on a case-by-case basis, whether this particular organ is usable or not usable, and obviously that includes a lot of factors there, not just how the organ status is. In a given recipient who is sick, even a borderline organ may be accepted there. So that makes it very important that the final decision that a particular organ should be used or not to be used should be left to the team which is handling the donor, and no organ should be closed without being assessed by the proper team there. So let's look at one by one organ. Let us start with the heart. These are the classic criteria that say when we can use the heart there. So this criteria, if you look at from the point of team who is managing the donor, we are looking at what all we need to know from the history, like what all things are relevant. Second, what are all the things that we need to do to investigate a donor from the cardiac perspective there, the investigations. Third, what are all the things that can be optimized to make a donor usable. So if you look at the classical criteria there, we need to look at obviously what are all the cardiac related history in these patients. Then when we look at what all investigations needs to be done, we need to get an ECG, we need to get an echocardiogram, and we need to get a coronary angiogram if a donor is more than 40 years age. This is how we need to go. Then for optimization, we need to look at what inotropic support this particular patient is on. When this criteria of considering the classical criteria was strictly used or followed, the number of organs that were available was far less. So they come in the extended criteria where even the organs with some issues like an advanced age or a ventricular dysfunction or even some treatable cardiac diseases can be considered for a heart donation there. So how it is assessed in a systematic way, this is how it is done from a cardiac perspective in a systematic way. The most important thing that you always look at is the weight. That is how you match the donor and recipient. To give an example, if we say that a particular donor is 70 kilo, your choice of recipient may be different. But once we go and see a particular donor rather than 70 is only 50 or 55 kilo, the recipient which was planned may or may not be suitable for that particular donor. So weight, an approximate estimation of weight is very important for matching between the donor and recipient from the heart perspective. You look at how are the pressures, how is the CVP, how is the ECG, how is echo, all parameters of echo in detail, and anyone more than 40 years, you get a coronary angiogram. So let's deal this with a practical case scenario. We have a young male who has become a brain dead organ donor. An echo done 1 day before is perfectly normal. These were the inotropes of this donor at this point, a 0.3 mics of noradrenaline and 3 units of vasopressin. A team goes and assesses the organ there. This is what they find it. The pressure was on bit on higher side, 148/100. The pulse was feeble. A tachycardia was there, and a blood gas shows both hypernatremia and some base deficit there. So when this team repeats the echo which was perfectly normal 1 day back when the echo was repeated, this is how the echo is. To elaborate, the patient is having a moderate left ventricular dysfunction with a normal right ventricular function. Along with that, there is some mitral regurgitation which was not reported in the echo done 1 day before. So what is the reason for this ventricular dysfunction? What is the reason for this new onset mitral regurgitation in this particular patient? If we look at that, the main reason for this, if you remember the vitals, the pressures was quite high in this patient, probably was getting vasoconstrictors much higher than what he needed. So we need to optimize this donor to make this heart usable. How do we do that? This is how we go about this. You taper the constrictors. You start a small dose of inotrope, say adrenaline or an inodilator like a dobutamine or a milrinone. You bring down the BP, which was 148/100 to a mean arterial pressure of 70 to 80. That is very important. And then you start filling the patient. If there is a scope for filling pressures in this patient, correct all the acidosis, hypernatremia, do the hormone resuscitation, and keep repeating the echo at regular intervals. So when we say keep repeating echo at regular intervals, how frequently this should be done? Ideally every 1 or 2 hourly, to see that what the changes we have done, did they made any changes pertaining to the organ function. So once all these were done, a repeat echo was done after some time. As you see here, there's quite a remarkable improvement in the cardiac function. And this particular donor, which otherwise would have become a not usable heart, has become usable at this point. So this is how a resuscitation makes a difference. Also, not every time we end up in getting an organ back after resuscitation. Quite a good number of times we do see that in spite of all your efforts, the heart further goes down. The heart goes down and over a period of 6 hours or 12 hours becomes something like this with a severe ventricular dysfunction, barely moving at all. So if we look at the, what are the features of this, this can deteriorate or develop over a few hours. As I said, over 6 hours or maximum 12 hours, this organ can go from a mild to moderate ventricular dysfunction to a severe ventricular dysfunction there. And this can develop across age groups. When we had donors as young as 2 years of age with a normal heart reported before, the heart becoming as worse as this. So this can develop across the age groups. And what are the clinical signs when we are monitoring a donor, how to pick up that this particular donor is going for a ventricular dysfunction? These are all the clinical signs. Whenever we have a high pressures or a high mean arterial pressure or a low pulse pressure or tachycardia unexplained, that indirectly indicates that this patient is going for a stress cardiomyopathy, and this has to be identified and handled early. Because in the early phase, there's always a chance or a possibility that this organ can recover and become usable. But if it is delayed, that won't be of any benefit. Whatever the resuscitation we try to do, the organ will go for a downhill course and become not usable there. So how does this impact the entire process of donation? To start with, we have seen that the heart has become bad. Obviously, the heart is not usable. Along with that, the patient will always have a risk of going into a low cardiac output there. So it's not just the heart. Over the period of next few hours, we see that because of the high left atrial pressures, the lung goes for a pulmonary edema of congestion. So this makes the lungs also not usable in this particular donors over a period of few hours. So eventually this pulmonary edema or congestion will lead to a right heart failure, and that has an impact by an increasing in the CVP, thereby leading to both liver and kidney also getting affected. If we see that a liver, especially with the good parameters in the beginning, once the patient gets unstable, the enzymes will be elevated and all. That is primarily because of this. You have a low cardiac output along with an increase in central venous pressure that leads to both congestive and ischemic changes in the liver, thereby making liver and kidney unusable. So this makes the entire process of donation nullified because all the major organs will become not usable in this particular donor. Also, once this becomes severe low cardiac output, there is always a risk of having a sudden cardiac arrest. A lot of times we do see and hear that the donor became unstable, donor had a cardiac arrest, donor has pulmonary edema, not able to do second apnea. A lot of causes for that, but one of the primary reasons that makes these donors unstable is a deterioration in the cardiac function or stunning. In this, only when picked up early can make a difference of resuscitating and getting all the organs back. To sum up, when it comes to the cardiac perspective, these are all the key points there. The main factor which we take into account when matching is weight, so communication of weight is very important there. There is always a risk of coronary artery disease, especially in Indians. Angiogram practically is not possible in most of the scenarios, so always have an assessment of the risk factors for the CAD in these patients. Previous echo, yes, is important, but it is very important that we keep repeating it at regular intervals to make sure that heart is good. Always avoid the high pressures in these patients, monitor the central venous pressure, and minimize the constrictors, have a targeted fluid resuscitation. This is how a donor has to be managed coming to from a cardiac perspective there. The next organ, if we look at from this, is the lung there. Before that, if we have any hypotension in a donor, it has to be approached obviously in a systematic way. The three common causes we see for hypotension in any intensive care unit is this. One is either the patient is hypovolemic or bleeding. Second, it is a septic or a vasodilatory shock. Or third one, it is a cardiogenic shock. So the approach for all these three are different, but you primarily identify using your bedside echocardiogram and looking at your IVC there. For a hypovolemic, you see a totally empty ventricles with a small IVC. On the other side, a septic and a vasodilatory picture will have a normal cardiac function and a reasonably filled IVC. When it is a cardiogenic, you always have a ventricular dysfunction. So for any donor who is having a hypotension, the main response should not be just an increase in the pressures, but rather identify what is the reason for this and then target that reason specifically. That's how it has to be approached there. So if we look at, do all these make a difference? A very targeted fluid management, appropriate titration of vasopressors and inotropes, yes, it does make a difference. This particular study is from Korea, from a single center which has seen close to 400 donors. And if you see here, the black line that is there is from this center. And when they looked at the study period where they optimized the donors based upon the filling pressures, adequate filling, cutting down constrictors, the organ utilization rate from that center during that period was far higher than any other place across the world reported at the same period of time. So this guided approach always makes a good difference for the donor organ harvesting. So let us look at the next organ, that is the lung. Lung has its own challenges. It has a very fragile organ with a very poor utilization rate. So that leads to a longer waiting time, high mortality, and more donor runs per recipient. That means for a single recipient, even if they are high in priority, to get one usable organ, we may need to go 3 or 4 times, at times more than that, to find an organ which is suitable for implanting in that particular recipient. So this is all the criteria what we look at from the lung perspective. You look at any relevant history and smoking, and if you look at the clinical parameters, any duration of ventilation more than 4 or 5 days is usually taken with a bit of caution for the worry of developing of infection there. Then most important thing is the PF ratio, which you want it more than 350 in most of these donors. There should be no infection, and a bronchoscopy done should be clear. So these are all the classic criteria when you look at how or when a lung is accepted there. To look at these things in a systematic way, how do you assess? The first thing you always look at is the height. That is how we do match between the donor and recipient lungs. When it comes to heart, it is always the weight. When it comes to the lungs, it's always the height that you compare between the donor and recipient. Then you look at your history, whether the patient is infected, and all the relevant imaging pertaining to this. Then you look at your blood gas, ventilator settings, and do a bronchoscopy, and finally do a cardiac assessment to make sure that there is no cardiac cause for a lung dysfunction there at this point. So we were always talking about a PF ratio, which we need to see in a donor. Why is it important? This is the reason. Any PF ratio which is on poorer side, usually the organ is not accepted, but even if it is accepted and taken every single parameter in the postoperative period, these patients do worse when compared to the ones who have a good PF ratio. So how is it usually picked up or missed? If we look at the sequence of events that happens in ICU of a donor, this is how it will be. If you just look at this as an ICU monitor there, as you see the patient is stable, he's on a ventilator support. In the initial first point, the PO2 was around 150 with FiO2 of 0.4. That translates to PF ratio of 375. A few hours later, the PO2 would have come down to 90 in the blood gas. But if you see the patient clinically stable, the monitor still shows 100% saturation. A marginal increase in FiO2 is what that needs to stabilize the patient, but that's not what is the point there. At this point, there is some reason why this lung has gone down. The PF ratio has come down to 375 to 225. Identifying this point where it has come down is very important, because action or looking at the causes for this at this point, still we can try to resuscitate and get back an organ. As you see, once we worked on this, the PF ratio improved and organ became usable. But on the other side, if this is not identified when it is in the early stage, this will lead to an organ becoming non-usable there. So this was the same what I was mentioning, more donor runs or the less chance of getting an organ. If you look at roughly the different time frames, the time patterns we have, close to 50% of the times you see that the lungs initially, when you get the initial alert itself, they're not usable. And even in that 50% of cases, when you go and assess the organ, it's only in a small fraction of them, 1/3 of them where the lungs will be usable. On the other side, the other organs, a lot of times in the initial assessment, when they're good, you usually end up in harvesting the organs, whereas the lungs, it's different, that a lot of times you end up in declining the organs. So what are the reasons that makes these lungs not usable? These are the ones: infection, which is very common, followed by aspiration, then fluid overload or a pulmonary edema secondary to cardiac dysfunction there. So these are all the main causes, and our management should focus on stabilizing these causes to make the lung usable. To just give an idea, this is how it will be even in patients with a good PF ratio, normal chest X-ray. Once you go and do a bronchoscopy, you do see that a lot of times, a lot of them will have a purulent secretions which make the organ not usable there. This is after declining the organs which are not good in the initial screening or by phone call there. And when you open and see, you do see that a lot of lungs will have consolidatory patches, which again makes them not usable. Again, the same slide what was before. These are the main reasons that makes the lung not usable. And let us look at one by one how to handle this. Aspiration, always an appropriate size endotracheal tube which is cuffed is extremely important, which is fixed at an appropriate mark. And regular checking of cuff pressures, simple measures do make a lot of difference. And head and up of the patient and good oral care. These simple measures like a good size ET tube, well inflated cuff, head and up position, and a good oral care makes a lot of difference in preventing the aspiration. Similarly, from the infection perspective, having a humidified circuit for the ventilation there and having a close suction and having sterile hand hygiene or handling practices, then regular imaging. These all do make a good difference in identifying or preventing the infection of the lungs there. Then when it comes to the pulmonary congestion, whether it is because of the fluid overload or because of the cardiac dysfunction, a close watch on the fluid status of the patient and cardiac status, you will be able to settle this well early by inotropes and diuretics to make the lung dry there. So how should we ventilate a donor? You go with this criteria. Always we do use a pressure control mode of ventilation if it is preferably. And then you try not to cross the 5 ml per kg of tidal volume and a peak pressure of not more than 25 and a minimal possible FiO2 as low as 30 or 35 just to keep your saturation stable. That is how you ventilate a donor there, and keep doing recruitment maneuvers. Make sure humidification is there. Make sure the closed suction is used for suctioning this patient. These all do make a good difference in maintaining the donor lungs there. So these all simple things, do they make a difference? This again is a single center study where in that study period of 3 years, if they looked close to 450 donors, if they look at the rate of lung harvesting, this has, what was 13% initially has gone up to close to 27%. That is, it almost doubled when a simple measures like what we discussed before were followed. So a lot of simple things can make a huge difference in the number of organs that are available there. So to close it as a key points for the lung, these are the ones we keep a close watch on the PF ratio to identify when the organ starts going down. Keep a good PEEP and recruitment maneuvers. Aspiration and infection prevention are extremely important, and we'll maintain a fluid balance and keep a close watch on the cardiac function there. To look at the other organs from the perspective of how a donor intensive care team should know, for the kidney, these are the things what we need: a function test, a urine analysis, ultrasound, and sodium levels. Again, for the kidney, the main factors which makes an organ not usable, the reversible factors are the ischemia and congestion that comes out of low cardiac output or a high central venous pressure. So maintaining a good cardiac output and an optimal hydration is extremely important for the kidney, and same stands for the liver. As a part of evaluation, yes, an LFT, ultrasound, sodium levels serially, these are all done, but the main modifiable factors that makes a liver non-usable is again ischemia and congestion that comes out of a low cardiac output state or a high CVP there. So that has to be very closely monitored. Other organs, a lot of them are harvested. These are the main things which we need to look into when managing the donor. For the intestine, it is the lactates and perfusion that needs to be always sustained. For the pancreas, a strict glucose control and make sure that no fluid overload. And for the hands, yes, it should always very important to avoid swelling. A venous congestion or extravasation probably makes the organ not usable like anything else. And cornea, most commonly harvested, should make sure that there is no exposure keratitis. To sum up about the organ management, the intensivist who is managing always has the time, which is a plus point there. They have the time to identify, optimize, and resuscitate back the organs which are borderline usable. From the heart perspective, dysfunction is very common, so a regular echo and minimizing your inotropes, vasoconstrictors is very important. For the lungs, it is the aspiration and infection which makes them non-usable. A close watch on PF ratio can help us identify when they're going down. For all the other organs, the main thing is maintaining the adequate perfusion and avoiding the congestion there. Infection control is extremely important to increase your organ utilization. Thank you once again. A lot of additional systems are there which makes the organs usable, but when we are looking at such a costly organ perfusion systems, simple methods make us even more impact, or they lead to much more organs than all these complex ones. Thank you once again.
Thank you, Dr. Murli. It was a wonderful presentation as always. Now, before I have one or two queries, I open it to the floor. Does anyone have any questions for Dr. Murli?
Hello, sir.
Hello,
Very nice
ma'am.
presentation, sir. Thank you. Sir, my question is, how would you go about for a transfusion for donors, sir?
HB of less than 7, especially when it's causing a hemodynamic instability, yes, it has to be transfused. Anything more than that, you have to see the situation and this one to look in that. What is not covered in this is a lot of donors do have an SIRS kind of picture, which makes them a bit coagulopathic. If you are in that situation, you do see that during the harvesting, they do bleed a lot. So you may end up in transfusing them, especially when HP is less than 7. More than 10, they don't need.
Sir, we here in RGGH, we maintain a hemoglobin of 10 grams generally. So, but what about the other products, sir? Most of them, they'll be in low platelet count with a PTIN or high PTIN. That's how we come across. I mean, the patients we get, most of them come after going to 2 or 3 hospitals outside, come to us in a vasoplegic state sometimes, in profound hypothermia with coagulopathies. So, how do you take about the products?
Coagulation correction, ma'am, it has to be very guided and specific. If we do have viscoelastic tests like a TEG or ROTEM,
can we go around by ROTEM, sir?
Yes, ma'am.
Do you have any protocol on that?
No, if it is a significant defect on the ROTEM and the patient is going for a surgery, obviously for the donor harvesting, it is better to replace the products. Yes. It may not be needed when the donor is in the stabilization period in the ICU, because obviously he has become brain dead status, so active bleeding may not matter there much unless there is an active ongoing bleeding. But during the harvesting or just before the harvesting, if there are significant coagulation deficits, probably transfusing makes them better.
Okay, sir. Thank you.
Thank you.
Yeah, thank you. Your presentation was an eye-opener for us. I also belong to Rajiv Gandhi Government General Hospital. So we look at the patient as a holistic person. Till now, we haven't really focused on the heart or the liver or the kidneys, because we don't know what the recipient hospital is going to, take. So we look at the patient as a holistic patient. One. Number 2, the protocols. We have changed over from methylprednisolone to hydrocortisone, and we have completely stopped giving hormone replacement because it did not offer much benefit. So these are the 2 things which we have totally switched off. And thirdly is, as Jayanti has rightly pointed out, we maintain a hemoglobin of 10 grams, and we do go by ROTEM, and we are very generous in replacing. We make sure that there is no DIC, and if we are not happy, we also call up the recipient hospitals and tell them, look, we are not happy with the ROTEM, you better be careful when you're doing the recipient surgery. So otherwise, as NGK sir was telling us, his presentation will be very different, and it was very different because we've not looked at the patient as organ specific. Thank you very much, sir.
Thank you.
Thank you. Thank you.
Thank you for the excellent presentation, sir. One doubt regarding blood transfusion. Though we do tend to give pack cells and other specific component therapy, as a nephrologist, I have a doubt regarding this donor who is potentially evaluated during the initial phases has been transfused. Now, subsequently, the blood is taken for cross-matching. Does any protocol is there existing to make sure that the blood of the donor, potential donor, before transfusion needs to be taken so that if there is a future need, that's one point. And can we go ahead despite transfusion for a cross-match? Thank you.
Transfusing a donor, I think not every time we have things under control, sir. Because as sir presented, 70–80% of time, still probably till last year, was all trauma cases. There's been increase in stroke cases this year, but most of the times it's a trauma cases. When we say we have a trauma case that's coming, obviously the patient will be like a regular patient till one point before he becomes an organ donor. So till that point, obviously there will be good efforts to get the patient back from a neuro perspective, unless it's a very bad case to start with. Till the time it becomes a possible donor and a team's takeover, probably we don't have full control on transfusion. Probably transfusions, in case of doubt there, again may be justified from the point of resuscitating the donor if there is any chance there. So if we don't have control, there's nothing we can do about that. But if we do have a choice of avoiding a transfusion in otherwise stable donors, when we say transfusion, like any other transfusion triggers or thresholds, we're looking at how clinically stable, how are the lactates, is there any adequate organ perfusion there at any there. These are the parameters we're looking at, obviously. So if we have an opportunity to avoid a transfusion in a clinically stable donor, it always is beneficial. So when it comes to that sampling point, very difficult to comment because we don't have the full control. Very few patients come to the hospital as a donor, and even if they come like that, they are in some other clinical center before they wait. They have already probably underwent a transfusion and all kind of.
I would like to congratulate Transplant and Dr. Gopalakrishnan in particular. It was a very impressive slide that you put on from 1,000 in 2023 to 1,500 in 2024. No doubt, the amount of donations across the state has increased. And it's very gratifying, being associated with Transplant for the last 20 years to see where we have come from where we were so many years ago. Although the number of donations and the number of centers, even non-retrieval centers, has come up, as a lung transplant surgeon, I'm sure Dr. Govini will agree with me, the harvest rate is still at a dismal 20%. Now, with your permission, sir, I would like to give just 2 take-home messages to all the people here. One, please ensure the ventilator is humidified. We have lost organs purely because the ventilator was not humidified, ventilated with dry oxygen and air, and when we go down the bronchoscope, we just see crust there and the lung is not usable. So could we please do that? So just 2 take-home points. The second is, for calculating the PF ratio, yes sir, we need 100% FiO2. But once you calculate, please turn the FiO2 down to the 30%. We all know when we ventilate with 100% oxygen, more than 24 hours, irreversible alveolar damage sets in. But sadly, sometimes we see young donors have been ventilated with 100% oxygen for 48 hours, 72 hours. So if we tackle just those 2, if all the coordinators are instructed in your checklist, ventilator, humidifier, potacha, number 1. After the ABG, the next step is turn the FiO2 down. If these 2 is done, I think the harvest rate would be more.
Exactly, sir. And I just add on to a few more points what Murali and Sundar sir said. See, there are 2 tubes are very important. One is the Ryle's tube. You have to position it properly. Most of the time, it is because of the aspiration. If you put a proper Ryle's tube in a position, then you avoid this aspiration issue. And second is the ET tube. ET tube should be proper size, need to be used, and it has to be well cuffed. Otherwise, what will happen? There will be a micro aspiration which goes into the lung because it's already ventilated patient. And second thing is ABG. As sir said, it should be done with a 30% or 40% of the time. Most of the time, what we get is the first apnea or second apnea ABGs. That may not give us a clear clue which organ is good, which organ is bad. Because PF ratio is very, very vital before we take your organs. And third one is a CT scan. CT scan, whenever you do a hair, brain, or abdomen, always better to run through it, even get a chest CT also. That is, we can able to read a better compared to the chest X-rays. So I just add these few points to sir as well. Please ensure, sir, that one.
Sure. Thank you for the wonderful presentation and very good take-home messages from the chairpersons. Thank you so much.
we have come a long way.
Let's move on to the next presentation. May I call upon Professor Dr. Anil Vaidya. He's the Director, Institute of Multivisceral and Abdominal Organ Transplant Team, MGM Healthcare, Chennai. I request the chairpersons, Dr. Swaminathan from Kaveri Hospital, Chennai, and Dr. Sendilnathan from GEMS Hospital, Chennai. Please take over.
Do I need to stand on this?
Yes, sir.
Thank you for the invite. I'm going to be talking about multivisceral transplants, but multivisceral transplant as such is a misnomer. We're really looking at intestinal transplants, and before we even understand what intestinal transplants are, I'll take you through intestinal failure. Intestinal failure is something that we need to understand before we get into the transplant of intestines. So the question, what is the role of intestinal transplantation in management of patients with these intestinal failure? Is it like a last-ditch therapy where no other therapy exists? Or is it really an elective treatment in patients who fulfill certain defined criteria? Is this really an academic pursuit of a very small group of enthusiastic people? When I say a small group of enthusiastic people, we may be around less than 100 people in the world engaged in intestinal transplantation. And again, it's important to understand the nexus between intestinal failure and transplantation. Transplantation of the intestine is reserved only for people with irreversible intestinal failure. So what is intestinal failure? We have three types. There are many ways to describe intestinal failure. This is the way I prefer it. The first one, as general surgeons, we know you had a Whipple procedure or you had an extensive general surgical operation. Your patients might go into ileus and may need TPN. Usually that's limited by about 30 days. It's self-limiting, patients get better. Type 2 is when there's a surgical catastrophe. Could be trauma, could be through elective surgery, but non-healing. These are the ones that will take a longer time to heal, and you can't use their intestines for their nutrition. And these are the ones that need special units to be able to take care of them long term. And type 3 is chronic intestinal failure, where there is irreversible intestinal failure. There's no way that this patient can be rehabilitated in any way. So type 2, we look at major intestinal surgery, septic and metabolic complications. It needs a multidisciplinary intervention, as I said, in specialized units. And these are the disease spectrums that look at how type 2 intestinal failure can happen. Top of the list is surgical complications. Crohn's disease, or IBD, which requires multiple resections over time, can cause people to be into type 2 intestinal failure. But the most important one, I think, in India is we're looking at gut ischemia. And I think we should move away from the time when in a center you find someone with gut ischemia, you open up, has come with abdominal pain, you see black intestines, and the temptation is to close the abdomen because the rhetoric is that there is no other treatment available. However, now what we're trying to do with intestinal transplantation is to say to those people in those centers, do take that black intestine out and send the patient to us. So surgical complications, Crohn's disease, are in the Western world one of the more important causes of type 2 intestinal failure. The management wherever the patient is remains the same. You got to take care of the sepsis, you got to focus on nutrition, check out the anatomy, and come up with a plan. So sepsis and wound care is very, very important for these people. The reason being, if you have sepsis on board, there's a problem with nutrient transport, motility problems, you have GI dysfunction, you have insulin resistance, malnutrition comes in, and you have persistence of intestinal failure. And sepsis is the most important cause of death in intestinal failure. You have a high index of suspicion for sepsis for patients who are presenting with type 2 or type 3 intestinal failure. There's a failure to thrive, there's hypoalbuminemia, and unexplained high output from their stomas or from the open wounds. Added to that is hepatic dysfunction. So we keep on getting standard blood cultures, even if the patient is not spiking fevers. Standard blood cultures, swabs, chest x-ray, abdominal imaging, and sometimes you need to have some bone imaging because this can manifest as infection in the bone. Nutrition is important. We look at enteral nutrition if they've got enough gut, but parenteral nutrition is the mainstay of these patients. We have to improve their nutritional status to restore their immune function, improve wound healing, have intestinal adaptation, and prepare the patient for surgery. And you can imagine this may take months. During that time, we look at anatomy. We have to be confident that this patient is in type 2 intestinal failure. We can be able to rehabilitate the gut by surgical maneuvers rather than going to intestinal transplant directly. So anatomy is very important. Usually we use water-soluble contrast versus barium to check the length of the intestine that's remaining. And then of course you come up with a plan. The plan could be medical, keep on TPN and what have you, manage small bowel syndrome or short bowel syndrome, or it could be surgical. Surgical depends on, can you rehabilitate the gut? Can you do some gut lengthening surgery? Or would they have to go to transplant? About 50% of patients with type 2 intestinal failure will land up with type 3 intestinal failure. And that's irreversible, and that's where the indication of intestinal transplantation is. This is an old slide that shows, but it's still consistent even to date, that inflammatory bowel disease in the West is the primary contributor for type 3 intestinal failure. But ischemia, which is more predominant here, is number 2 in the West. And there are various factors that might affect who can get rehabilitated. And the most important ones are if your age is over 60 when you present with type 2 or type 3, or your jejunal ileal length is less than 50 centimeters. Moving on from intestinal failure, we know now intestinal failure has got 3 types, 1, 2, and 3. Now we've got a patient with type 3 intestinal failure and we're moving on to intestinal transplantation. So this has been the newest kid on the block, intestinal transplantation. There are 3 things that we look at in common, or 3 organs that we've transplanted. One is the lung, the second is the intestine, and the third is the skin. The common thing between these 3, all 3 are exposed to the environment, and the immunology is similar. So we take a few pages of each chapter from each transplant organ system, and we try to apply the immunology to intestinal transplants. So there was a first successful series was done in 1990. Everyone thought that this is the thing to do. Very, very, a lot of centers expanded very quickly, but a lot of centers stopped expanding and stopped their transplant proceedings also quickly. They could not sustain what is required of an intestinal transplant center. The problems of rejection and translocation, we think, are partially resolved, but there's a lot more things happening on the immunological side. The indications, these guidelines haven't changed in the last 25 years. Impending or overt liver failure is no longer something that we see with type 3 intestinal failure because we've gotten better at saving the liver from TPN-associated liver damage. Thrombosis of 2 or more major venous accesses or infections, repeated infections of your venous access that you use for TPN. Since we've gotten better at intestinal transplantation, we're looking at tumors as perhaps one of the indications for transplantation. Again, quality of life plays a major role here. People might think they do not want to live with TPN all their life, and therefore it brings about, is there a patient choice? This is a slide showing conditions in the adults, mainly shortcut syndrome because of ischemia, volvulus, trauma, Crohn's disease, and others. In the pediatric age group, it's a bit different. They're mainly congenital anomalies that lead to shortcut syndrome. And this was a good slide showing that trauma and tumors are the rising numbers in terms of patients referred for intestinal transplantation. Our assessments of potential candidates is we ask ourselves 3 questions. Is it possible to do? Is it safe to do? And will it be beneficial for the patient? And that requires this multidisciplinary team and collaboration with referring centers, with your gastroenterologist who referred the patient to you. And is transplantation appropriate? And if so, when should you transplant? Because in the Western world, you have TPN or home PN as an alternative to transplantation. And there's a balance between, the technical aspects of intestinal transplantation, rejection, sepsis, versus, you're losing venous access, you got sepsis, you got liver damage, so you got to weigh the balances. The constraints have been consistent, the surgical and technical, because these are the patients that may have had more than 15 abdominal operations before they come to you. The immunological factors of intestines, as I said, mimics those of lung and that of VCAs, and we got to take a little lesson from each organ that's been transplanted and learn from each other. There is possibility of infections and cancers, and it is really crucial for the timing of the referral. The timing of the referral tells us how well the patient will do after the transplant. As I said, surgical, multiple prior operations, scarred abdomen, abdominal wall, open abdomen sometimes, they have diseased vessels, thrombosed veins, and you have nothing else to work with. This is a typical patient, and that's what you see, a patient that comes to you, frozen abdomen, and you have to try and take all that out. And this is a picture in the top right is the G tube, and you got to take all this out, cocoon out, and replace it with transplanted organs. These are the types of grafts. Right now, when we list our patients, most of them are isolated intestines, the top left. The liver and intestine has gone out of practice, so has liver, intestine, and pancreas. So the isolated intestine on the top left and the 2 down on the bottom right are what we actually do nowadays. That's the multivisceral and the modified multivisceral. The isolated intestine is the easiest one to do because there's only one inflow and one outflow. You can either connect it to the portal system, or you can connect it to the systemic, to the IVC. We don't do this anymore. So this gets a bit more technical because this is replacing everything except the liver. So when you explant, you are careful. You've disconnected the portal flow, but you're careful to keep the hepatic artery flowing. And this is the multivisceral transplant. I think this is the easiest one to do because this is an en bloc. There's only one inflow and one outflow. And immunologically, this one makes more sense because of something called the cluster of grapes theory. The cluster of grapes theory says that if you have one inflow that goes to everyone else, your outcomes are better, immune recognition is better. You can do an experiment, get a whole cluster of grapes at home, and get another cluster and take the grapes individually out and store them. You'll see that the cluster of grapes lasts longer than the individual grapes. This is an example of a multivisceral graft. It's face down, so the aortic graft is facing you. This is what an isointestinal graft will look like. As I said, you can do a systemic or you can do a portal flow. Doesn't make a difference. We tried both. Having said this is intestinal transplantation, when you do an intestinal transplant, you have an abdomen that's scarred. It's loss of domain. You're trying to put an intestine in, but you're not going to get cover. So the closure of the abdomen becomes a very important thing when you're doing intestinal transplantation. So closure of the abdomen could be primary. Sometimes you have domain that's preserved and you can close the abdomen, or if there's a donor-recipient mismatch, the donor is bigger, recipient was smaller, you can close. Sometimes people use a delayed closure method. Some people use prosthetics. And what we like to do is abdominal wall transplant. And this falls in well with the first talk of the day. As I said, they have multiple intestinal resections, near total enterectomy, weight loss, and you can see a scarred abdomen. You're going to try and get through there, put intestine, and try to close it. There's poor quality of native skin. There could be multiple endocrine fistulae, high-judgment fistulas, called excoriation of the skin. And there's usually healing by secondary intention, or there could be radiation damage for people who've got radiation enteritis. So what I'm trying to say is that the skin, the quality of skin, and the loss of abdominal domain forced us to do something like this. So what we have done is also transplant the whole abdominal wall from the same donor. This is a composite vascular allograft, and that's how it looks. We get it on the inferior epigastric pedicle, and we identify the inferior epigastric pedicle in the recipient, and that's how it looks when it's inset. This is how it looks in the post-op. Sometimes we're not able to finish the primary operation, that is the intestine or the multivisceral. It's taking a lot more time, and your abdominal wall is in cold solution, and you want to get it reperfused. So we devised this new technique of reperfusing it remotely. It's not new. I mean, it was done by Sushruta, 4,000 years ago. We're using the same technique of primary operation going on. Separately on a hand table, we reperfuse the abdominal wall through the non-dominant vessels in the forearm. And if the patient is now unstable from the primary operation, what we do is just bring the forearm close by and close the abdomen. This is another example of a abdominal wall on the non-dominant forearm. This is remote revascularization. In this patient, we looked at the inferior epigastric. Patient was stable. However, the flow from the inferior epigastrics was not good enough. When we put it there, was not optimal perfusion. So we put it back on the forearm and closed the abdomen. And this guy was post-op. 3 weeks, and we detached it from the forearm about 6 weeks later. Immune surveillance is important for these people because there's high risk of rejection. So I came up with this, I invented this, I stumbled on this about 14 years ago in Oxford, that there is something called the immune paradox. If you transplant a skin flap with the primary organ, that's the intestine. And this was my very premature description of why this happens, and it all depends upon the amount of dendritic cells in the skin. The secondary protection is because the dendritic cells in the skin will say, please switch off. If you don't switch off, and there's overflow, it goes to the regional lymph nodes, which will direct the immune attack to the skin, not to the primary organ. This is the evidence that we came up with doing mechanistic studies at Oxford, and we proved that the use of a forearm skin flap that's vascularized in intestinal transplantation may help in protecting the intestine. This is what it looks like. It's got an artery and a vein. We open up the forearm and do a look at the non-dominant artery and its vena comitatis. And that's how the flap looks like. This is how it looks like after surgery. This is how rejection looks like. Now, you could imagine that the flap has got rejected, but the intestine is still normal. There is no rejection in the intestine. And this, you can take a biopsy and quantify the rejection. Again, the same phenomenon in the abdominal wall grafts. There's rejection of the skin, but the intestines are preserved. We do punch biopsy of the skin. We look at interface spongiosis and decide what is the grade of rejection happening, and then treat it. This is after treatment. As long as you treat the skin flap, your intestine's always going to be safe. Coming to the evolution, we've got technical evolution. We've added donor spleen. We now do a gastric anastomosis. We do transplant colons also, and we do expanded use of cut-down grafts. Post-operative management, as everyone knows, immunosuppression, infection, nutrition, monitoring of the grafts, and of course you can have PTLD or GVHD. Immunological aspects are the major challenge because rejection is common, but ever since we started using the forearm flap, our primary organ rejection rates have dropped drastically. So immunosuppression, again, is a balance of toxicity versus rejection and sepsis. We prefer to use very strong up-end antibody induction through Campath, and we maintain with only one drug. The amount of graft that you're transplanting, people say that you need at least triple immunosuppression. That is not true, and we moved away from triple maintenance immunosuppression to monotherapy. We do CMV prophylaxis. Nutrition is started right away with trickle feeds, and we move to complete oral absorption usually around by the 7th or the 10th day. Rejection can happen. This is a rejection where you're seeing on the right side there's complete loss, but you got to be patient. You got to treat the rejection, and it takes about 30 days for rejection to heal, which is why our forearm flap is much better, because there's no rejection in the intestine. Rejection in the skin is something that you can treat, but you do not have to put these people back on TPN because their intestines are still functioning. Treatment rejection is by steroids or antibody therapy. If it's severe ACR, we might have to take the graft out. Microbiology is the same as any other transplant. The timing of transplantation is very important. Ideally, before morbidity increases, like your line access is gone, irreversible liver damage, and you've got to define that interface between TPN and transplantation. It works pretty well. Majority of the cases have got full function. Results are improving over time. There's registry data. Survival is improving over time. And median hospital stay is getting lower. That means we're getting better at what we're doing. Causes of death has remained as sepsis. This is consistent over two timelines, and sepsis is mainly because of rejection and translocation of bacteria. The Indian perspective, I think, is driven by financial constraints, and I think it is better to transplant earlier rather than having TPN and what have you. So this is a take-home message here. For intestinal transplantation in India, for it to really blossom, I think transplanting earlier would be a better option. Use innovative methods of immune monitoring that can be remote, because the patient could be at home and monitoring the skin. As long as the skin is free from any rash, the intestine is going to be good. This is one of my patients that sends pictures of the abdominal wall grafts and the skin over it. As long as the skin is looking good, she doesn't need to come to the clinic. So the answer, I think, intestinal transplant has come of age. We've moved from experimental, high-risk rescue procedure to a validated, life-saving therapy with clear indications. There's standardized techniques and steadily improving long-term results, much like the trajectories of kidney, liver transplants have followed decades earlier. And thank you.
Thank you, Dr. Anil Vaidya, for the excellent overview of intestinal transplant. And you started off rightly by saying that you are an elite select set of transplant surgeons venturing into intestinal transplant. I'll start the questions by saying that from Indian perspective, what are the challenges? Because you worked at various centers across the globe, what is probably one or two single major deterrent for intestinal transplant? You, in the beginning, said that the number of transplants are less compared to liver and kidney. Nevertheless, the need is there. We were just discussing the need is there. So what needs to be done from Indian perspective to increase the number of transplant? What are all the friction points for us to run over to have a proper, well-defined intestinal transplant units across India?
I think that's a fantastic question. I think that there are two things to that. One is awareness that there is a specialty that's available, and the other is cost. And you have to be able to understand that if you do not decrease the cost of TPN, the amount of time taken for patients to be stabilized, and then the cost of transplantation is a humongous cost for patients. So awareness, one, from the doctor's angle, that actually there is now a service that can be accessed in very, very specific cases. But how do you bring down the cost? And what me and my group, Dr. Dinesh is sitting there, we've been trying to do is, during that phase when the patient first comes to us, you're not going to rush into the operation. It's not an emergency operation. It's not like acute liver failure. You've got to stabilize the patient. He has got a formula of within 4 or 5 days in the hospital, line is placed, cultures taken, line placed, TPN started, refeeding taken care of, and patients are then removed from the hospital system to home. And it is our team. We've got a very extensive home TPN team that goes to patients' homes, connects them to TPN, disconnects them from TPN, and takes care of them at home. We have rapidly cycle the TPN down to 12 hours, and that TPN happens only during the night. The only complaints we get from patients is that they have to go to the toilet in the night because they're getting TPN, they're getting a lot of fluid. But we are managing to keep them infection-free, and the costs are completely reduced because there are no hospital costs involved. So I think that is important. I think there's got to be maneuvers to try and decrease the cost, overall cost. And as I said, awareness, trying to talk to many, many more doctors in different cities, say, if you do come across a patient like this, we have the way. Not only do we look at home PN, but also Dinesh's team goes to that, that patient, wherever the patient may be in India, and lifts the patient and brings him back. So we've established that network that hopefully will decrease the amount of costs involved, as well as the the intensity of treatment that is perceived by patients.
Are there any government funding system at the moment for intestinal transplant?
There isn't right now, but we're trying to apply for that. But they will perhaps fund the transplant, but not the main thing is to take you through stabilization before you have a transplant. The nutritional stabilization, that's TPN, keep you away from line infection. That package may not come under the government purview, which is why we're concentrating there to make sure that the costs are much reduced there.
Any questions from the floor?
I have a question.
Yes.
Is alemtuzumab-based induction immunosuppression, is it the same practiced across the globe, or it's your choice?
So alemtuzumab came to the forefront only in the late 90s. And it came to the forefront after we wrote one of the biggest randomized controlled trials on alemtuzumab versus normal induction agents. It's 800 patients in both arms, and we published in the Lancet. After that, people have started taking alemtuzumab really seriously, because previously it was thought that alemtuzumab is like a neutron bomb, and you're going to have all patients coming with infections and what have you. That is not our experience. As the intestinal transplant centers go, majority of them are now moving to alemtuzumab, but they were using alemtuzumab wrongly. They were giving alemtuzumab before implantation, and we changed that theory at Oxford. The mechanistic studies we did in Oxford defined that you have to give alemtuzumab after reperfusion. You need to have the antigen-antibody cohort mix, recognize each other, get ready to attack each other, and then you give alemtuzumab to silence everyone. So then at 3 months, what you see coming back is a whole cohort of Treg cells. And that's where the advantage of alemtuzumab comes in.
Thank you.
My last question is, how do you select between intestinal lengthening procedure versus intestinal transplant?
So that's a good question again. We wrote this paper of 500 cases from Cleveland Clinic on intestinal lengthening procedures. And there's a very select criteria. As I said, one of the slides that I showed you, if your age is more than 60, and if the amount of jejunal ileal segment we're looking at is less than 50 centimeters, and no colon or IC junction, it's a direct slingshot to transplant. If you've got 100 plus centimeters, a bit of a dilated segment, you can do a reverse segment and dilate that segment, then yes, there is a chance of lengthening procedures. However, the key factor in India is all these lengthening procedures, there is a 64% chance it will work. So 64% chance you pay a lot of money for that, recuperation, complications from that, but at the end of 3 years, you might be back on TPN. So the question in India is different. It's a very different economic ball game here.
Close. think if there are no more questions, thank you, Dr. Anil Vaidya, for enlightening us on a less traveled road. Thank you very much.
So let's move on to the last segment of the program. It's a panel discussion. I call upon Professor Gomathi Karmegam to initiate the proceedings. And also the panelists, Professor Balamurugan, Professor of Neurosurgery, Madras Medical College in Nadu Government Hospital, Dr. Jayanti Mohanasundaram, Assistant Professor Anesthesia, Madras Medical College, and Dr. Gayatri, Associate Professor Anesthesiology, Government Erode Medical College and Hospital, Perundurai.
So, a very good afternoon. Pre-lunch. Let's see how many of you I can wake up. So I hope to keep this very practical and very extempore. மூணு பேனலிஸ்ட்டுக்குமே என்ன பேச போகிறோங்கிறது வந்து எதுவுமே டிஸ்கஸ் பண்ணலை. எந்த கொஷின்ஸுமே we've not pre-prepared anything. So whatever the discussion is, we wanted to pertain maximum to the protocols of how the BSD certification actually happens. So we have neurosurgeon Professor Balamurugan sir, we have Professor Gayatri madam, she is from IRT Perundurai, and she is part of a non-transplant organ retrieval center, and Dr. Jayanti, she has been my partner since 2021. So this discussion is going to be very interesting. Let's see how their perspectives are. In the mari oru team நம்ம கூப்பிடும்போது we will understand how difficult it is working in a team. நம்மளோட outcome focus நிறைய theory பார்த்திருக்கோம் காலையிலேருந்து. But when we work as a team, each of our aspects and our outlooks are different. So let's see how different it is and how unified we are in the end. So starting from Bala sir. I think I'll take a mic. Audible, sir? Am I audible? Audible, right. Starting with Balamurugan.
Yes, ma'am.
Now, Rajiv Gandhi is a very, very busy place.
Yes, ma'am. Your mic is not functioning, I think. Directly you can speak from there.
Okay. Rajiv Gandhi is a very busy place.
Yes,
we are not in shortage of any patients. We get so many patients every day. How will you identify a potential brainstem dysfunction patient?
Yes, ma'am. Based on the patient's neurological status and absence of brainstem reflexes, mainly the conscious level, the GCS, Glasgow Coma Scale, it should be 3. And clinically all the brainstem reflexes should be absent, like corneal reflex, gag reflex, and the pupil should be dilated and not reacting, and the doll's eye movement should be absent, and the caloric test should be positive. So these are all the classical brainstem reflexes, it should be absent. Then from the time of admission, when we receive the patient, suppose if we receive the patient at the early morning 6 o'clock, we can do, if all these clinical brainstem reflexes are absent and all, during the initial evaluation, we will wait for 6 hours. Always we will wait for 6 hours, and then only we will give identification. Till that time, we will keep the patient as a potential brainstem dysfunction. Meanwhile, we will do the biochemical evaluation, and ABG also we will take And if the parameters are within normal range, we can go for identification. We can go for identification after 6 hours. That is the routine we are following, ma'am.
So that is very clear. So this is from a neurosurgeon's perspective as well as a neurologist. The neurology team follows
Almost
protocol
similar,
now.
yes.
So coming to Dr. Gayatri, you do not have the luxury of having a neurosurgeon or a neurologist. So I think the same scenario exists in Dharmapuri also. So how do you manage? How do you identify?
Good morning to one and all. First of all, I would like to thank Transplant, the organization, for giving us the golden opportunity. And I would wholeheartedly my thanks to our past and present deans, Professor Valli Satyamurthy Madam and Dean Ravi Kumar Sir, for giving us very good support and encouragement to continue this program as it goes on. So in our place, we have only one neurosurgeon. So he is on call 24/7. So we receive the cases only because of him. Only one neurosurgeon in the neurosurgery department. We have a neuro ICU. So the patients are coming for only the treatment of head injury, not for organ donation. So at whatever may be the situation, at the end they want some percentage. They have some hope that the patient will be treated and will be alive. So either the patient comes initially with identification from the spot. We see that the patient is having GCS of 3/15, or the patient coming with 5/15 or something and getting surgery done, and they are in ICU. The next day, he is getting the ICU treatment. The next day, when we see maybe after 6 hours or 8 hours, he is showing the signs of brain death. Or we are receiving patients who are identified from outside, some private hospital or some government hospitals, showing features of brain death, and they come here mainly for if they are able to do anything, otherwise for organ donation. Nowadays the awareness is very, very much that they want, okay, if it is brain death, okay, do the procedures fast and give us the mortal remains. So there are 3 types of patients we are getting. So who is to identify? That is the main point. Who is there following up the patient? There should be one coordinator who is always having in the mind of which patient is coming with GCS 3/15.
So excellent. So you've heard from 2 perspectives, a neurosurgeon who has definitely a lead way in catching the patients earlier, and from the NTORC center where she needs to treat all patients. Any patient who walks in has to be treated first before we can classify them into the BSD category. Coming to Jayanti, now Balamurugan sir has identified, and he has, he is yet to declare. So what are your difficulties that you will face during that period?
You meant to say the patient is potentially brainstem dysfunction, but not
yet
declared as
declared.
severe. Okay, but I would say there is an advantage and disadvantage. The advantage being that you can catch up the patient early, treat his hypotension, or the organ perfusion can be maintained better if we get hold of the patient earlier. And I hope there won't be any intervention from the neurosurgery mostly. Sorry to say that, sir. So, like anti-edema measures with the 3% NS or mannitol, which will badly reflect on the electrolytes later on. So those things will be avoided if they can give us a heads up by declaring potentially severe brainstem dysfunction. But the disadvantage being my team will be overworked because these potential brainstem dysfunction patients may not be the ideal patients with a very high senior age group like 80 plus, or with a poor lung, or the patient will have a very unstable hemodynamics. Such cases we'll be wasting our time rather than potentially using it on a ideal candidate. But again, we don't have the luxury to do that. Each patient deserves their treatment. But the team becomes overworked for longer hours. before declaring severe brainstem dysfunction.
So exactly, it's easy to identify patients. It becomes slightly more difficult as we are trying to optimize them so that the neurosurgeon can declare them. Now coming back to Bala sir, when the patient is now identified, you have declared the patient. Now your anesthesia team or the BSD maintenance team has optimized everything. All the parameters are within normal range, and you are convinced about the E1, VT, M1, there's no cranial reflexes. Now, you have declared that this patient is a BSD. You have declared. Now, how will you communicate to the relatives, sir? At that juncture, this is for the purpose of coordinators who are here. What is it that the treating physician will tell to the relatives?
Yes, ma'am. Actually, the first question from the patient might be, sir, is there any எப்படி இருக்கார் சார் ஏதாவது வாய்ப்பு இருக்கா இதான் ஃபஸ்ட்டு ஜென்ரலாக அவங்க கேட்கக்கூடிய கொஸ்டின். ஜென்ரலி வி வில் சே தட் இஃப் தெர் இஸ் எனி பாசிபிலிட்டி ஆஃப் டூயிங் எ சர்ஜரி டு இம்ப்ரூவ் டு கிவ் சம் பாயிண்ட் ஆஃப் இம்ப்ரூவ்மெண்ட் ஃபார் தம் தென் இட் இஸ் ஓகே. அதர்வைஸ் சான்ஸ் இல்லாமல் இட்ஸ் எ சிவியர் ஹெட் இன்ஜுரி, இந்த பிரெயின் ஸ்டெம்லாம் ரொம்ப சேதமாயிருக்கு. ஸோ சான்சஸ் ஆஃப் சர்வைவல் ரொம்ப மோசமாக இருக்குது. அண்ட் we are doing all the investigations, we are treating the patient at the same time, but chances are very remote அப்படிங்கிறத சொல்லுவோம். தென் பிரெயின் ஸ்டெம் ரிஃப்ளெக்ஸஸ் ஆப்சண்ட் அப்படின்னு வரும்போது கரெக்டாக கடைசியாக சொல்கிறது வந்து மூளையை கண்ட்ரோல் பண்ணக்கூடிய அந்த மையப்பகுதியே டேமேஜ் ஆகிருக்கு. ஸோ ஹார்ட், லங்ஸ் எல்லாமே இப்போது டேமேஜ் ஆகிருக்கு. இப்போ பாருங்கன்னு சொல்லி வி வில் டிஸ்கனெக்ட் த பேஷண்ட் ஃப்ரம் த வென்டிலேட்டர் அண்ட் வி வில் ஷோ இட் டு த பேஷண்ட். ஜஸ்ட் ஒரு 5-10 செகண்ட்ஸ் காமிப்போம். ஸோ இதுவுமே இல்லை, ஒன்லி நாடி துடிப்பு மட்டும்தான் இருக்குது, இதை வச்சு தான் போயிட்டுருக்கு. ஸோ இட்ஸ் வெரி டிஃபிகல்ட், சர்வைவல் வெரி டிஃபிகல்ட் அப்படிங்கிறத சொல்லிவிட்டு தென் வி வில் இன்ஃபார்ம் த மெயின்டெனன்ஸ் டீம் அண்ட் த கோஆர்டினேட்டர், கிரிஃப் கவுன்சிலரை அப்போ உள்ளே கொண்டு வந்துடுவோம். ஸோ தே வில் டேக் கேர் ஃப்ரம் தட் பாயிண்ட் ஆஃப் டைம். பிகாஸ் அஸ் பர் அவர் கைட்லைன்ஸ் நம்ம ஆர்கன்ஸ் பற்றி அவங்கள்ட்ட பேசக்கூடாதுங்கிறதுனால எந்த அளவுக்கு தெர் இஸ் அ சான்ஸ் ஆஃப் ப்ராபபிலிட்டி ஆஃப் சர்வைவல், சான்சஸ் ஆஃப் டிட்டீரியரேஷன் ரெண்டையும் எக்ஸ்பிளைன் பண்ணிவிட்டு தென் maintenance team and grief counselor will take care. அதுக்கப்புறம் அவங்க they will continue.
Exactly. So coordinators here, please note that the primary physician at the time of declaring the patient, attenders கிட்ட அப்பவே we do outline that prognosis is not okay, but we are proceeding with the maintenance because we want a diagnosis. இவர் மூலச்சாவு அடைஞ்சிருக்காரு அப்படின்னா சில டெஸ்ட் நாங்கள் பண்ண வேண்டியது இருக்கும் அப்படிங்கிறத நம்ம தெளிவாக அந்த சமயத்தில் நம்ம சொல்லிடுறோம். ரைட். கம்மிங் டு தி டூ anesthesiologists, Gayatri.
Madam,
yeah,
I have one
I'm
doubt.
coming to you. How will you, the same scenario, how will you, because now you do not have the luxury, you have only one neurosurgeon, and I'm sure, I don't know how much he communicates. You will be there, I think, more often than him. You will be more available. So how will you talk to the attenders?
Ma'am, actually, many of the times we find the patient in the daytime and he's there to inform the patient attenders. He will say the prognosis. Sir, I have one more doubt, sir. So now the patient is having 3/15 GCS with spontaneous respiration, another patient with a GCS 3/15 with no spontaneous respiration. How will you go for the surgery, sir? That is where I am held up, madam. Yes. Because sometimes patient will ask, for example, the patient is coming at night 9 o'clock with a 3/15 with a spontaneous respiration. So they will ask, will the surgery improve the patient's status? So that time we are held up. We don't have any answers.
As per our institutional guidelines, madam, if there is no spontaneous respiration, pupils are not reacting. Even if the patient is having acute subdural hematoma, we don't operate. If the patient is having respiratory efforts and if there is slight movements of the patient, we will give a chance. We will do the surgery and we will reassess after 6 to 8 hours. At that time, if there is no signs of improvement, then we will go for identification.
So you proceed
that
for decompression craniotomy when the spontaneous is there?
Is there, yes.
Oh, thank you, sir. Thank you. So, madam, what we do is we call the attenders and we say these are all the signs of brainstem death, but we cannot confirm it. We are just treating the patient's vitals because most of the time we receive the patient in peri-arrest status. Almost only carotids are present with 150 heart rate, and immediately we rush the fluid with 1 liter. Then we proceed for CVP insertion and arterial line, and we stabilize the patient. Then we shift the patient to the neuro ICU. After that, after 2 to 3 hours only, we communicate with the patient. So he's showing the signs, and after that we will tell them we will wait for another 6 hours to make sure the diagnosis, the signs are
So this is
confirmed.
the take-home message for coordinators. Attenders will, family will accept you when they see that the team is actually trying to treat the patient. நீங்கள் எடுத்த உடனே அந்த பேஷண்ட் வந்து பிரெயின் டெட் அப்படின்னு சொன்னீங்கன்னா யாருமே உங்கள்கிட்ட பேசவே மாட்டாங்க. But when they actually see the team treating their family member, they are more likely to accept us. So that is bottom line. Coming to Jayanti, இப்போ சார் வந்து ஐடென்டிஃபை பண்ணிட்டாரு, டெக்ளேர் பண்ணிட்டாரு. ஃபர்ஸ்ட் அப்னியாவுக்கு நீங்கள் யூ ஆர் கால்ட், யூ ஆர் ஆன் டியூட்டி தட் பர்டிகுலர் டே, நீங்கள் வர்றீங்க. நீங்கள் அப்னியா பண்ணுறதுக்கு முன்னாடி அட்டெண்டர்ஸ் கிட்ட சொல்கிறீங்க, இந்த மாதிரி நாங்கள் இந்த செயற்கை சுவாசத்தை யூஸ்வலாக நம்ம சொல்லுவோம் இல்லையா, செயற்கை சுவாசத்துலேருந்து கழட்டி ஒரு 10 நிமிடங்களை பார்ப்போம், 3 டாக்டர் கொண்ட குழு பார்ப்போம், ரத்த டெஸ்ட் எடுப்போம், முன்னாடியும் பின்னாடியும் பார்ப்போம். அதில் கார்பன் டை ஆக்சைடுங்கிற ஒரு அந்த கேஸோட அளவு வந்து 20% ஜாஸ்தி இருந்ததுன்னா அவங்க மூளைச்சாவு, மூச்சு விடணும், மூச்சு விட்டாங்கன்னா அவங்களோட பிரெயின் ஆக்டிவிட்டி இருக்குதுன்னு அர்த்தம். ஸோ ஆல் தட் நம்ம எக்ஸ்பிளைன் பண்ணுறோம். இப்போ நடுவில் அந்த அட்டெண்டர் வந்து உங்கள்கிட்ட சொல்கிறேன், மேடம் இந்த கை அசைஞ்சிச்சு, எங்கள் அப்பாவோட கை அசைஞ்சிச்சு, நீங்கள் மூளைச்சாவுன்னு சொல்கிறீங்க, எங்கள் அப்பா கை அசையுது, how will you tackle?
Hello. Thank you for that question, madam. Actually, the most frequently asked question. One thing we should consider is the patient attenders are in the height of their emotions. They are at loss. They are losing their loved ones. We should not just snap them by saying adala appadhaan irukum. We should not say that, never. We should try to educate them about the reflexes depending on their understanding capability. If they are, there are a variety of patients we get, some from very affluent, well-educated society who have a better idea about brainstem reflexes, brainstem death. Even then we have to explain that இந்த மாதிரி மூளை தண்டு செயல் இழந்துருச்சுன்னா அதுக்கு கீழே இருக்க நரம்பு மண்டலம் வேலை செஞ்சுட்டு தான் இருக்குது, ஸ்பைன் கார்டு நல்லா தான் இருக்குது, அது கை கால் அசைகிறது வாய்ப்பு இருக்குது. ஸோ இந்த லாசரஸ் ரிஃப்ளெக்ஸ் how much ever is possible in their understandable language we have to explain, which we routinely do. And also they sometimes they ask like இவ்வளோ தூரம் கை அசைச்சா மூச்சு விட்டுருவாரா, அப்போ வந்து மூச்சு விடுறதும் வந்துருமா, அப்புறம் தே ஃப்ரீக்வெண்ட்லி ஆஸ்க் இப்போ டியூபை டிஸ்கனெக்ட் பண்ணிட்டீங்கன்னா அப்போ வந்து அவருக்கு உயிருக்கு ஆபத்தாயிடாதா. தீஸ் ஆர் த கொஸ்டின்ஸ் வி கெட். That's why we encourage them by saying that we'll be a team of doctors. If something goes wrong, we'll be immediately resuscitating the patient. We will abandon the procedure. And I generally say that if you have to hold your breath for some time, you will not be able to hold on your own. Your carbon dioxide will build up and make you to breathe. The same thing we are trying for the patient. That's what I try to explain.
Excellent. So this is how Lazarus பற்றி, அதாவது involuntary movements பற்றி attenders கேட்டாங்கன்னா தயங்கக்கூடாது, மறைக்கக்கூடாது, அவங்கள கூப்பிட்டு சொல்லிடணும். சார் இப்போ கம்மிங் பேக் டு பாலா சார்,
எஸ்பெஷலி ரைட்லி பாயிண்டட் அவுட் மேடம், லசரஸ் சொல்லும்போது எப்போவுமே வி ஷுட் நாட் பிஞ்ச் த பெரிஃபரல் பார்ட் ஆஃப் த பாடி. நீங்கள் கையை கிள்ளி பார்த்துட்டு பேஷண்ட் அந்த பேனிக்காக அந்த ஆங்ஷியஸ் ஸ்டேட்டில் கையை திரும்ப பிடிச்சி அப்பா அப்பான்னு தட்டி கிள்ளி பார்த்துட்டு இருப்பாங்க. வி ஷுட் எஜுகேட் தம், இப்படி இல்லைம்மா வி ஹாவ் டு அட்ரஸ்ன்னு சொல்லி சுப்ரா ஆர்பிட்டல் நாட்சில் பெயின் கொடுத்து தட் இஸ் த ஐடியல் சைட் டு அசஸ் த ரிஃப்ளெக்ஸஸ். ஸோ சுப்ரா ஆர்பிட்டல் நாட்சில் பெயின் கொடுக்கும்போது இஃப் தேர் இஸ் இருக்கா இல்லையா, பெரிஃபரல் பார்ட்ஸில் கொடுக்கும்போது இருக்காங்க, வி ஹாவ் டு டிஃப்ரென்ஷியேட் இட். அதை நம்ம ஆஸ் அ டாக்டராக வி கேன் எஜுகேட் தம், சொல்லிட்டா தே வில் ஈஸிலி அண்டர்ஸ்டாண்ட்.
எக்ஸாக்ட்லி. நான் அதுதான் அடுத்து இவர்கிட்ட கேட்கணும்னு நினச்சேன். சார் வந்து இப்போ என்னோட கொஸ்டினிங் எப்படி போகுதுன்னு நீங்கள் கண்டுபிடிச்சிட்டிங்க. ஸோ எப்படின்னா இப்போ அனஸ்தெட்டிஸ்ட் சொல்லிட்டாங்க, இருந்தாலும் வந்து அழகாக வந்து பேஷண்ட் ஃபேமிலி வந்து சொல்லுவாங்க, நான் கிள்ளும் போது எங்கள் அப்பா அசைச்சாரு, காலை தட்டும் போது இந்த அந்த அந்த கால் நெகம் வந்து அசைஞ்சிச்சு, கால் விரல் வந்து அசைஞ்சிச்சு. அப்போ as you rightly said, you have to point out that it's a supraorbital pain. So read sternal pressure, sir.
Sternal விட இதுதான் பெட்டர் மேடம், ஏன்னா இது கொஞ்சம் கூட ஸ்பைனல் ரிஃப்ளெக்ஸஸை we have to avoid. That's why the ideal site is supraorbital.
Excellent. Gayatri, do you have any experiences with the involuntary movements?
Only one case, madam. One case where, as he was referred from peripheral GH. This patient was having 3/15 GCS with hypothermia, with a severe hypotension. We resuscitated the patient, kept warmer and everything. He started breathing. He started breathing. So actually, before that we tried for the apnea test, but there was some movements of the body. So because of the resuscitation, maybe he got all the reflexes back, but we did not proceed with that. After that, we went for, as you said, sir, decompression craniotomy, but anyway, the brain damage was severe. So we have seen in 1 or 2 cases.
But how did you communicate to the family?
The family, they understood, ma'am. Because once the patient is not opening the eyes, because we show that the infusions are only of inotropes and vasopressors, and we are not giving any sleeping medicines. So we show other patients. So they are opening their eyes, they are breathing on their own. They are not at all opening theirs, not moving at all. Only the laceration very rarely. So they believe. Literally the awareness is more, madam. Now the acceptance is very high.
ஸோ இதில் வந்து டேக் ஓ பாயிண்ட் என்னென்னா பேஷண்ட் அகெயின் கம்யூனிகேஷன். இந்த ப்ரோக்ராமோட அப்பார்ட் ஃப்ரம் தியரி ஆப்டிமைசேஷன் ரிசர்ச்சேஷன் எல்லாம் இருந்தால் கூட பேஷண்ட் ஃபேமிலிக்கிட்ட நீங்கள் எவ்வளோ அழகாக கம்யூனிகேட் பண்ணுறீங்கிறது தான் பாட்டம் லைன். எங்கெல்லாம் வந்து ஃபிசிஷியன்ஸ் நல்லா கம்யூனிகேட் பண்ணுறாங்களோ அந்த இடத்துல திஸ் ப்ரோக்ராம் வில் டெஃபினெட்லி டேக் அ வெரி குட் ட்ரஜெக்டரி. ஸோ ப்ரீவியஸாக மூலச்சாவாக இருக்குமோன்னு சஸ்பெக்ட் பண்ண பேஷண்ட் கூட மூச்சு விடும்போது when that family is able to accept you, that means your communication has really been top notch. So that is our drive home point there. Very good. I think that needs a round of applause. It's not easy. It's not easy. ஏன்னா அவங்க தனியாக இருக்காங்க, ஈரோடில் இருக்கிறாங்க, தர்மபுரியிலையும் இதே மாதிரி தான் சிச்சுவேஷன் இருக்கும். It's not easy. Sitting in Rajiv Gandhi, it's very easy for us. We have so much of a crowd there. We have support. Everything is easy. But sitting at Erode, it's not at all easy. Right. ஸோ 2 apnea நம்ம பண்ணிட்டோம். ஹூ டாக்ஸ் டு தி ஃபேமிலி பாலா சார்? 2 செகண்ட் apnea பண்ணிட்டீங்க, இப்போ ஹார்ட் துடிச்சிட்ருக்கு, ஃபேமிலி கிட்ட எப்படி எக்ஸ்பிளைன் பண்ணுவீங்க?
பேஷண்ட்ஸ்ட்டு சொல்லுவோம் மேடம். ஆக்சுவலி கடைசியாக நிற்க போகிற செயலில் மூளைச்சாவுங்கிறது படிப்படியாக ஒவ்வொரு ஆர்கனாக செயலிழந்துக்கிட்டே வர்றது தான். ஸோ லங்ஸ் முதல்ல அதோட செயலிழந்துடுச்சு. இட்ஸ் ஃபங்க்ஷனிங் பிகாஸ் ஆஃப் த வென்டிலேட்டர் சப்போர்ட். தட்ஸ் வை வி ஆர் டூயிங் த apnea டெஸ்ட் அண்ட் ஆல் டு ப்ரூவ். அண்ட் கடைசியாக ஹார்ட் நிற்கும், அவ்வளோதான். இன்னும் கொஞ்சம் நேரத்தில் அது எவ்வளோன்னு சொல்ல முடியாது. சில பேஷண்ட்ஸ் சில நாட்கள் அல்ல சில மணி நேரங்கள் அந்த மாதிரி தான். ஸோ இந்த மாதிரி வந்துடுச்சு அப்படின்னா இதுக்கப்புறம் சான்சஸ் ஆஃப் சர்வைவல் அப்படிங்கிறது இன்னைக்கு கிடையாது. ஒன்லி பிகாஸ் ஆஃப் த வென்டிலேட்டர் வி ஆர் ப்ரொலாங்கிங், அதர்வைஸ் சான்சஸ் ஆஃப் சர்வைவல் கிடையாதுங்கிறத
எங்கள் அப்பா செத்துட்டாரா சார்?
கிட்டத்தட்ட அப்படின்னு சொல்கிறோம்
சார். ஆனால் ஹார்ட் துடிக்குதே சார்.
அதுதான் கடைசியாக நிற்க போகுது மேடம். அது எப்போ வேணால் நிற்கலாம்
சார். அப்போ நீங்கள் எங்கள் அப்பா உயிரோட இருக்கிறாரா இல்லையா சார்?
முடிய போது வென்டிலேட்டரில் வச்சிருக்கிறதுனால மெயின்டைன்.
நீங்கள் செகண்ட் apnea பண்ணியிருப்பீங்க, ஹார்ட் துடிச்சிட்டு இருக்கு. ஜெயந்தி, நீங்கள் எப்படி சொல்லுவீங்க?
Ma'am, after the second apnea is over, generally that is the time considered as the time of death for the patient. This itself is very new to the family, and they will definitely ask us, ஹார்ட் துடிக்குது, எப்படி டெத் ஆகிட்டாங்கன்னு சொல்லுவீங்க? We have faced these many a times. Even to some extent, staff nurse will not accept to put an yellow card saying that it is not yet over, the body has not gone to the mortuary, how can I declare death now? So in that case, we try to explain that மூளை சாவு அடையிறத டெஸ்ட் பண்ணுறதுக்கு தான் 2 apnea டெஸ்ட். 2 apnea டெஸ்ட் முடிஞ்சதுக்கப்புறம் அவங்க மூளை சாவு அடைஞ்சிட்டாங்கங்கிறத உறுதி பண்ணுறோம். ஆனால் இருதயம் தானாக துடிக்கிற ஆர்கன் அது எப்போ நிற்குங்கிறது நம்ம கையில் கிடையாது. ஒன்லி சப்போர்ட் தட் we are not prolonging their life, we are prolonging only by giving the support to maintain the BP and heart rate, that's all. Even some patients will go and ask, போதும் எங்களுக்கு கொடுத்துருங்க, give the body to us, we will take the patient to our home. You said he is dead now, then give up the patient. Then I have to explain that this is unlawful in our state. In Tamil Nadu, it is not lawful to disconnect a patient by saying that he is brain dead even after second apnea test. So we say that we can minimally reduce the supports, or we will not escalate the support, but we have to wait for the heart to stop on its own to hand over. And most of the cases we receive are MLC cases who require post-mortem, even if they become organ donor or not a donor. So PM has to be explained to the patient, and most of them, if they become a donor, sometimes they come and ask us, request us not to do PM. then we have to explain that it is mandatory because it is a medical legal case to get even any benefits of the patient like some life insurance or pension, anything, they need disclosure. So it is a must to do PM and we have to explain very.
Excellent. So second apnea will be the time of death ingarada family attenders ku definitely nama sollanum.
That is
In
what
the
we
case
are
of
writing
angio,
in the case sheet also. Madam.
yes.
Time of death we are putting it as a time taken from the second apnea
Yes.
sample edukra time.
Exactly.
After that heart stopped at and potu or
Yes.
line we are adding.
Yes.
That is the
இதை
routine.
வந்து தெளிவா அந்த ஃபேமிலிக்கு கட்டாயம் நம்ம எடுத்து சொன்னோம். அதே மாதிரி if we are going to do ancillary tests like cerebral angio, then that will be the time of death. See, the family should be very clear that we are not taking organs from a living person. அந்த ஒரு புரிதல் வந்துருச்சுன்னா the whole program will fall into place. Next question is with Gayatri. I heard, I think maybe last year, there was a patient who was admitted at Coimbatore Medical College or ESI, I do not remember, or some private hospital, declared as an E1 VTM1, but the patient was brought to Erode for retrieval because you maintained the patient well in Kelipatan.
Coimbatore Medical College, we don't get cases, madam. They have their
One
own
particular
team,
patient which was brought to because the other colleges were not willing to maintain or some.
No,
Did
no.
you-
Actually, what happens is, madam, most of the Erode patients, they go to straight away to the Coimbatore corporate hospitals. Immediately after the injury, they are taken to the Coimbatore corporate hospitals. They want to save the patient at any cost. So they are observed there, they are treated in the ventilator and they are maintained there for minimum 12 hours to 24 hours. So by the 12 to 24 hours, the doctors observe that there are signs of brain death. So what they want is they bring back to the patient to their native place so that the declaration, the postmortem, everything is easy, the procedure. So usually that is almost 4 to 5 cases, they came from Coimbatore for this purpose only.
So, coming to Bala sir, supposing this our donor is from out of Tamil Nadu, what is the difficulty there, sir? Will you still go in and certify, declare, or should we not proceed in such patients?
We will discuss with the combinedly. We will discuss with the management and then only
With
we
the
will
management.
Take the decision.
So, any patient who has a difficult history, maybe mysterious
and
RTA,
unknown cause like
Unknown
assault and unknown patients we are not certifying, madam. That is
anything
also
else, sir? Unknown,
mainly,
out of state?
Mainly assault and unknown. RTA inside state we are routinely doing. That's all.
Exactly. So this is for the other patients. So coming to Jayanti, what is your experience with the HIV patients or hepatitis B patients? Is there any separate protocol that you have?
Yes,
Have you not maintained such patients in the past?
When the patient is coming to us as severely brainstem dysfunction, sometimes we do not know the viral status of the virology is sent and don't have the reports. But during the course of the time, you get to know that some patient can be positive. But if I remember correctly, we have given a HBsAg positive donor from our RGGH, madam. It is up to the recipient team to decide on taking the organs or not. And as for HIV, it is not taken. I think it's an absolute contraindication till now. I have discussed this.
Any other contraindications?
Madam, well-blown viral bacteremia or like in encephalitis, something like that, HIV patient and positive dengue positive patients. Because they say after the transplant, the recipient will not do well with the virology in the donor. That's what only I know. This particular case I discussed with one of my senior assistant professors long back, and she said like if it is a HBsAg positive patient, you can start antiviral drug in the recipient according to the titer viral load in the donor. And we have done one case HBsAg positive, madam. And they have, I think they have a separate list with positive patients for that. Yes. Waiting list for recipients.
Gayatri, have you had any experience with
No, madam. Till now, we have not done any positive case, madam.
Not done any.
We have not received it.
Right, sir. So let's come to the attenders are coming to you, Bala sir. Sir, நான் உறுப்புதானம் பண்றதுக்கு சம்மதிக்கிறேன் சார். ஆனா என் பையனுக்கு வந்து ஏதாவது ஒரு வேலை இருந்தா எனக்கு கொடுங்க சார். Because you are the primary physician. We know only you.
பட் ஜென்ரலி அந்த மாதிரி டாக்ஸ்குள்ளே நாங்கள் போகிறதில்ல மேடம். ஐடென்டிஃபிகேஷன் பண்ணிவிட்டு கொடுக்குறதோட
சார் இந்த
முடிச்சுக்குவோம்.
பர்டிகுலர் ஃபேமிலி உங்கள்கிட்ட வர்றாங்க சார்.
ஸ்பெசிஃபிக்காக கிரீஃப் கவுன்சிலர்கிட்ட காமிச்சிருவோம் மேடம். அதுதான் ஐடியல். ஏன்னா அது தென் தே வில் டேக் அ நியூ டர்ன், அன்னெசரியாக ஏதாவது கொஸ்டின்ஸ் வரும். அதனால் நாங்கள் அதை என்கரேஜ் பண்ணுறதில்ல. ட்ரீட்மெண்ட் பார்ட்டை எக்ஸ்பிளைன் பண்ணிவிட்டு மூளைச்சாவை பற்றி கேட்டால் அதை நம்ம எக்ஸ்பிளைன் பண்ணலாம். இஃப் இட் இஸ் பெனிஃபிஷியல் ஃபார் அதர் பேஷண்ட்ஸுங்கிற அளவுக்கு கூட we can explain, we can motivate them அட்லீஸ்ட், அவ்வளோதான். அதுக்கப்புறம் ஃபுல்லாக கிரீஃப் கவுன்சிலர்ஸ் வில் டேக் கேர். we are having excellent grief counselors, நல்லா பண்ணுறாங்க. they are doing the great job. These parts they are taking care very well.
So Jayanti, how will you?
I can add to that. Mostly I believe that the maintenance team is known to them more than the physicians, in the sense we travel with them for more than 24 hours almost. Till the time we hand over the body, we are with them. So they become very closer to us and we also become bonded to the family more. So what I generally explain to them is, there is no possibility of giving a job to the kith and kin, or there is no directed recipient in this. When they will ask, my close relative is needing a kidney, can you ask them to give that? They'll be helplessly asking us. They are not having any motive to ask those questions, but in desperation they will ask this. So we should make it very clear and say that it is not possible, because it goes by the rule, and there is a transparent app for that. Video app is there, and you cannot go and do anything. And I generally say that even I do not know who is getting the organ. So it is a confidential information, and there is no possibility of monetary benefits out of this. These things, it's better to make it very clear to the nearest kith and kin, rather than anybody else giving a false hope to the family.
Exactly. Gayatri, how do you go about communicating?
Yes, ma'am. Every patient asks this.
Everybody does ask.
Every patient attenders, they ask this. So, if the coordinator is available on the spot, we will directly transfer the patient to them. If
when do you introduce your coordinator? Which part? Is it after the first apnea?
Mostly after the first apnea, madam. Mostly after the first apnea, because we don't have in-house coordinator. We will inform him about the potential donor. So because sometimes it may be present, the positive or negative. So we don't want them to be staying here. It may take 6 hours or 12 hours. Sometimes apnea test may go for failure, abandon, or anything. So we make sure apnea test is positive before calling the coordinator. So whenever he is available, we will totally, but till that time they will not be having the questions. So once the first apnea positive only, they will be asking all those questions. So mostly we will transfer the patient. But if he is not available, we will definitely, even at the end, after the handover of the body, they will be asking, we are suffering too much, can any help can be provided to us regarding the job or anything. So we will see it later. We will not tell them straight away no, but we will talk about it later. First we will do the procedure and handover of the body. Thank you.
So usually இது ஒரு ரொம்ப common question. Gayatri madam வந்து after the first apnea, she says she will introduce the coordinator. Rajiv Gandhiல வந்து we wait until the second apnea. But the coordinator will be inside the room when we talk to the attender. So அவர் அங்கே ஹாஸ்பிட்டல் வார்டில் தான் இருப்பார் யூஸ்வலாக. ஸோ செகண்ட் அப்னியாக்கு அப்புறம் we definitely introduce the coordinator. That is, if the family shows some inclination in donating. Otherwise, we normally do not introduce. So only if they show inclination. அது ஒன்று. ரெண்டாவது, we are very clear and we are very blatant. So donatingங்கிறது வலது கை கொடுக்கறது இடது கைக்கு தெரியக்கூடாது. இதுக்கு பேர் தான் தானம். தானம்ங்கிறது இதுதான் தானம். எதுவுமே எதிர்பார்க்காம பண்ணுறது தான் தானம் அப்படிங்கிறத ஒரு 4 தடவை சொல்லிடுவோம். So they sort of understand. But this is very important. They will bargain with us with 2 or 3 things. Postmortem, நாங்கள் டொனேட் பண்ணால் போஸ்ட்மார்ட்டம் பண்ணாமல் இருக்கலாமா, நாங்கள் டொனேட் பண்ணால் நீங்கள் எதாவது கொடுப்பீங்களா, அப்புறம் நீங்கள் எவ்வளோக்கு சீக்கிரமாக கொடுப்பீங்க. ஸோ இது எல்லாமே Transplant, the coordinators have to do a very, very good job when they talk to the attenders. Sari sir, so retrieval is done. How long does the video lab take, sir, for allocation?
Immediately பண்ணிடுறாங்க.
It takes anywhere between 6 to 12 hours. Is it shorter for you, Gayatri?
6 hours
out of curiosity கேக்குறேன்.
Ma'am, after the second, actually, this is where the coordinator role comes. So immediately after the first apnea, the coordinator will come. So most of the patients are willing to donate. I will say around 90 to 95%. Even if any person says, I am not willing to donate, I will not ask the coordinator to leave, just to be in the ward. Within 45 minutes, they will come with the decision that we want to donate. So it only takes minimal. This is rare nowadays. Maybe in the first case or second case, they were waiting. They said we want to think over it. But nowadays, they are ready to donate even on admission.
Immediately after the GO 331, people, our public awareness has definitely come
Many
up.
times they come with, okay, somebody said signs of brain death are there, so
But how
make
do
it
you
possible.
tackle the family during the allocation process? The allocation process will take
Yes,
anywhere
ma'am.
between 6 to 10 hours.
Definitely. When we are allocated with the MGM or Kaveri hospital, it takes minimum 6 to 8 hours to come. So that's okay. But if the organ is going, well and good. But if it is declined, we are not able to convince them. So it takes more and more time. Minimal, the app takes minimum 4 to 6 hours, minimum 4 hours. By 4 hours, the allocation is completed. But sometimes everything gets, all hospitals reject the kidneys and another hospital pops in newly. The hospital once rejected in the first round, they can accept again. So that takes some more time. So, but if the hemodynamics is stable, we are allowing it. If the hemodynamics is not stable and the patient's attenders are too anxious, so we had to decline the long distance recipient hospital. That is only because of the attenders, not because of the...
So again, the family has to be very, very conducive to our, in fact, we are really stretching their limits of patience. The healthcare, the science has improved so much that all of us are, we will be able to maintain a patient even for 15 days. The protocols are very, very strong. But the problem arises with the patients, with the patient's family. So normally they become impatient. They have become anxious. They want to take their loved one home. So,
and moreover, this regarding the liver, sometimes the surgeons want to take the biopsy. So for us, Coimbatore is the center. So the sample is again going to Coimbatore, getting processed, and the results will come in minimum 2 to 2.5 hours it will take. So the process will be again waiting for another 2 hours. Sometimes the patient attendants may not...
Now this patient is on table.
On table. So we have to again talk to the attenders. Our coordinator does all the job.
Have you had any experience of the patient being on table, gone for biopsy, and the patient has arrested on table?
No, madam, not like that. One patient, while shifting, he was in peri-arrest stage. At that time, the surgeons were so... Till shifting, he was having 97% saturation and the BP of 130/80. On receiving, suddenly the saturation dropped down to 87. We immediately shifted and we started adrenal drip. The surgeons were so cooperative that they performed the surgery very fast and they were able to put the eyes with a running heart. And luckily the heart team was not there, so there was not much time. The kidney and liver team, they harvested easily. So that was the only one case. It was not a...
It becomes like donation after cardiac death, like near
Almost,
scenario.
it was
Almost
running.
like that. We had one situation where the saturation dropped to 80%. Jayanti, do you remember that patient? The saturation was sort of dwindled down from 99 to 92 to 88. Both of us were sitting inside the BST room. 85 kapro, it did not increase at all. The allocation was over, the recipient hospitals had come, both of us had to shift the patient to the theatre with a saturation of just 85%.
That's what we were suspecting, madam. Sudden drop never occurred. Maybe in one case, in 1 in 20 or cases. So that was the first time we had the patient with peri-arrest. Maybe due to any venous embolism or something, any pulmonary embolism or something. I couldn't find the cause at all.
No, we don't have a cause.
Yes.
But the bottom line was the surgeons were so fast.
Yes.
Almost all the entire recipient team came in. They were very fast. They finished the surgery very quick. So, yes. You remember that patient,
Yes, madam, yes, we proceeded with the retrieval. Yeah, I remember
very
that
fast.
case.
Sir, post, just before handing over, how do we pay respects to the family, sir?
Now We can only, in our hospital only, Thiranirajan sir started this nice gesture. Now the government has make it as a policy. We are doing with the proper, we are doing proper tributes to them, so that they will have that sense of feeling, that emotional thing is there. And we are giving due respect for that. It's a mutual thing. It's a nice gesture started by our sir, and now it's a mandatory, we are following it over the Tamil Nadu.
Jyoti, before the advent of honor walk, do you recall how we used to send the patients?
If I remember correctly, it was either you or me standing with the family to say the pay respects, and it was what to say, like before this was one program where my duty never ended with the OT. Once the patient is done, PM is done, we clean up and take the patient down to the family, and whoever possible hospital doctors were there, we used to assemble and pay respects with the garland and send them off. But one fine day with one patient, Kirti, 20-year-old female from I think Telangana, and we started the honor walk in the midnight. And that time I remember like more than 300 medical graduate students were assembled, and it started off like that.
It made a terrific difference. ஏன்னா அந்த ஆனர் வாக் முதல்ல நைட் 11 o'clock நடந்துச்சு.
Late night.
First time டீன் சார் வந்து 11 o'clock வந்தாரு, and there were about 150 students at that hour. We were able to assemble, and on either side அது பார்க்கவே வந்து அது ரொம்ப நெகிழ்ச்சியான ஒரு 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 சம்பவம் தான் அது. And the family இன்னைக்கு வரைக்கும் they are in contact with us. So it's a beautiful thing. Gayatri, how did you start the honor walk in Erode?
Ma'am, actually first or second case the honor walk concept was not there. So our Dean Madam, Valli Satyamurthy Madam, she will always be in touch with me when the surgery, when it is starting, when it is ending, she will be continuously following up the case. And once we are ready with the packing and everything, Madam will come and she will honor the patient and she will talk to the patient attenders. She will be consoling the patient. So after the honor walk came, so depending upon the time, even our present Dean Dr. Ravi Kumar sir and medical superintendent ARMO, RMO, everybody will be there. So if it is very late night or something, we assemble a group of people with the OT people who has just finished, and our nurses, matron, and staff nurses, house surgeons, and everyone. Minimum 25 to 30 people will be there. So our ARMO will be the person whoever is on the duty, ARMO and nursing matron and nursing superintendent. All of us, we go and do the honor walk along with our coordinator.
So actually there should be an active participation from the institute head.
Yes.
So wherever, in whichever places the institute head has taken an ownership to the program, that particular hospital will definitely have a very good outcome with regards to this program.
Nowadays we involve students, madam. MBBS students, all the years we have gone and we have informed them, so they have to participate in honor walk. So actually some more work is pending, so we have to again motivate the students, because sometimes they have gone for vacation and exams are there, and weekends we cannot expect many people. That's my own problem.
But it's okay, even if there are only 20, the gesture of honor walk should never be lost, or it should not be stopped at any cost, because that is the final time you get to pay respects to the departed soul. So coming to that, NGK sir, can I take any questions from the floor which anybody would like to ask the panelist? Please, mic kudukala. Any question to me or to the panelist? பரவாயில்ல, நிறைய பேர் கொஸ்டின் கேட்குறீங்க, சந்தோஷமா இருக்கு எனக்கு.
Yeah, please go ahead. And before that, just one clarification. Actually, the viral positivity status is not an absolute contraindication. As it has been pointed out, we have donated patients with hepatitis C and hepatitis B also. And even HIV is not an absolute contraindication. Only thing is that much of acceptance rate is not there. What we do now is that we give the offer for the recipients who are HIV positive. Whereas in the Western world, it has gone beyond that as well. Even a HIV positive donor can donate to HIV negative recipient. But of course, there are certain the other tests that have to be run, like, you have to quantify the viral copies in the donor. And there are certain protocols as the prophylactic ART to be started in the recipient and so on. We haven't really proceeded that way, to that level. But now, in the year 2024, we have identified and retrieved organs from HCV positive and HBV positive. Yeah. A couple of questions quickly. We are running short of time. Maybe we'll.
We can take 2 or 3 questions.
Good afternoon, madam. I'm Dr. Suresh from Jain Medical College, madam.
Good afternoon.
First apnea test patient attendance inform
First apnea test
First apnea test the patient should be informed or attendance should be informed or
Sir, whatever government setup, whatever you do, you have to inform the attenders. It is a practice which we do not do, but நீங்க ஒரு வென்ஃப்ளான் போடும்போது கூட நீங்க family கிட்ட சொல்லும்போது
any verbal consent or written consent?
It's not a consent. It is an information which we அதை பகிர்ந்துக்கணும். ஏன்னா இப்போ வென்டிலேட்டர் செயற்கை சுவாசத்தில் இருக்கிற ஒரு நோயாளியை அதை நீங்கள் 3 பேர் சுற்றி நின்று அதை கழட்டி பார்க்க போகிறீங்க. அந்த இடத்துல அந்த பேஷண்ட் இறந்து போயிட்டாருன்னா அவங்க என்ன நினச்சிட்டு இருக்காங்க, அவங்களோட உறவினர் உயிரோடு இருக்கிறாங்கன்னு நினச்சிட்டு இருக்காங்க. ஸோ டெஃபினெட்லி இட் இஸ் நாட் கன்சென்ட், இட் இஸ் அன் இன்ஃபர்மேஷன் that has to be shared to the family. So Bala sir.
Yes. That information should be recorded.
Not necessary. Not necessary. We have never recorded that. Yes, Bala sir.
And in fact, there is a government order. There is a government order that every brain death has to be certified. So, for performing apnea test, no need to take consent at all.
Yes.
Because in fact, government has mandated brain death identification certification in all patients.
If unable to revive, what we can.
சார் அதையும் நம்ம ஃபேமிலி கிட்ட முதல்ல சொல்லிடணும். இந்த அப்னியா டெஸ்ட் ஆனது செய்யும்போது இதயம் நிற்கிறதுக்கோ இல்லை பிபி குறையிறதுக்கோ இது மாதிரியெல்லாம் பிபி குறைஞ்சாலோ சேச்சுரேஷன் குறைஞ்சாலோ ஹார்ட் ரேட் குறைஞ்சாலோ நாங்கள் இமீடியட்டாக திருப்பி செயற்கை சுவாசத்தில் வச்சுடுவோம். இவருக்கு ஏற்கனவே தீவிரமாக மூளைச்சாவு பிரெயின் அஃபெக்ட் ஆகிருக்கிறதுனால ஒருவேளை ஹார்ட் நின்னா நாங்கள் சிபிஆர் கொடுக்கலாமா வேண்டாமா அப்படிங்கிறதும் நம்ம அட்டெண்டர்ஸ் கிட்ட முதல்ல பேசிடுவோம். ஏன்னா அவங்க டெக்னிக்கலாக என்ன நினைக்கிறாங்க, இப்போது பேஷண்ட் உயிரோடு இருக்குதுன்னு நினைக்கிறாங்க. ஸோ ஃபஸ்ட் ஆப்னியாவுக்கு முன்னாடி இந்த மாதிரி தான் வாட் ஐ வுட் டூ இஸ் ஐ வில் டெல் தெம் ஹார்ட் நின்னா நாங்கள் சிபிஆர் கொடுப்போம். அவங்க ஒருவேளை இல்லை மேடம் விட்டுருங்க, அவங்க நரம்பு டாக்டர் சொல்லிட்டாங்க ஆப்ரேஷனும் பண்ண முடியாது, பொழைக்க மாட்டார், கோமாவில் இருப்பார், விட்டுருங்க அப்படின்னா வி டேக் இட் அட் தட். ஆனால் ஃபஸ்ட் ஆப்னியா பண்ணிவிட்டு அது பாசிட்டிவ் ஆகி அரெஸ்ட் ஆச்சுன்னா ஆஸ் அ டிக்டம் we do not do CPR because now we have told the family attenders that ஃபஸ்ட் ஆப்னியா ஒரு மூச்சு விடலை, மூளைச்சாவு தான், 2வது ஆப்னியாவுக்கு வெயிட் பண்ணுறோம் அப்படின்னு சொன்ன பிறகு நீங்கள் சிபிஆர் பண்ணுறீங்க அப்படின்னா இட் இஸ் ஓன்லி ஒன் மோட்டிவ். Yeah. Sir, and according to American Heart Association guidelines, it is very clear we do not resuscitate in a patient with brain stem death. Exactly.
Sir, one more information,
Bala,
sir. The first apnea, during the first apnea, not all patients they go for arrest. Not many patients.
Yes,
we need not go for in a hurried manner. We don't do first apnea test unless all our investigation come. So we do all the CT scan, X-ray chest, ABG, RFT, LFT, everything, and we stabilize the patient and we come down on support. Then only we perform the apnea test. So when the patient is clinically unstable, definitely the first apnea test is going to fail, or the patient is going for arrhythmia. So we don't rush for first apnea test until the patient is getting stabilized, sir.
Sir, Bala sir,
many
would your
times
input,
abort பண்ற மாதிரி தான் ஆகும் சார். டீசேச்சுரேட் ஆகிறது, டக்குன்னு ஒரு 85க்கு கீழே போகிறது, ஒரு இசிஜி சேஞ்சஸ் அது இருந்ததுன்னா we will discuss with the anesthetist and stop the procedure. அவ்வளோதான், அதுதான் பண்ணுவோம் ஜென்ரலாக. அது ஏர்லி பிக்கப், ஏன்னா எல்லாருமே டீமாக தான் பண்ணுறோம். ஸோ வெரி ரேர் நீங்கள் சொல்கிற மாதிரி சடனாக போகிறதுங்கிறது எப்போ ரேராக நடக்கக்கூடிய இன்சிடென்ட். மோஸ்ட் ஆஃப் த டைம் ஏர்லி பிக்கப் பண்ணாலே ப்ரொசீஜர் வில் பி டிஃபர்ட். அதோட அபார்ட் பண்ணிவிட்டு திரும்ப அகைன் வி வில் டூ இட். அவ்வளோதான், அந்த மாதிரி தான்.
ஸோ இட் டசன்ட் அரெஸ்ட். நம்ம அந்த அரெஸ்ட் போகிறதுக்கு முன்னாடி நிறுத்திடுவோம், அப்னியாவை அபார்ட் பண்ணிடுவோம். ஸோ இட் ஸ்டாப்ஸ். தேங்க்யூ.
ஆஃப்டர் செகண்ட் அப்னியா ஆக்சுவலி 4 பேர் சைன் பண்ணல மேடம்.
எஸ் சார்.
அதில் அட்மினிஸ்ட்ரேஷன் வந்து சைன் பண்ணுறாங்க. ஆர்எம்ஆர் ஏஆர்எம்
பாலா சார்.
நியூராலஜிஸ்ட், நியூரோசர்ஜன், ஃபிசிஷியன் பண்ணலாம், சர்ஜன், ட்ரீட்டிங் டாக்டர், ஏஆர்எம்ஓ.
எஸ் சார். தட் ஏஆர்எம்ஓ ஷுட் பி எம்பேனல்மெண்ட் பண்ணணுமான்னு கேட்குறேன்.
எம்பேனல்மெண்ட் வேண்டாம் நினைக்கிறேன். எம்பேனல்மெண்ட் வேண்டாம்.
சார் என்ஜிகே சார் ரிகார்டிங் எம்பேனல்மெண்ட் கேட்குறாரு.
ஏஆர்எம்ஓ எம்பேனலில் வருவாரான்னு கேட்குறாங்க.
Actually, no need.
No need, yes.
No need. Because
Not required.
Only thing is that no, they should have been identified as ARMO. There should be a known designation as ARMO. With the name and designation should be there in the seal.
Yes, அவ்வளோதான்.
Yes sir. Thank you. Any other questions?
Another only one question, madam.
Sir.
Most of the time, neurosurgeons வந்து earlier identify பண்ணிடுறாங்க மேடம். Even in 4/5 they give the case. But anesthetist வந்து ஒரு cough reflex இருக்குன்னு சொல்லி கொஞ்சம் டிலே ஆயிடுது.
டிலே ஆகக்கூடாது சார்.
டிலே ஆகாது மேடம், அனஸ்தட்டிஸ்ட்னால
டிலே ஆகக்கூடாது.
அப்படி டிலே ஆனதுன்னா ஆஃப்டர் 3/5 வந்ததுக்கப்புறம் மோஸ்ட் ப்ராபப்லி பேஷண்டோட ஹைப்போடென்ஷன் அண்ட் ரெக்கவரி கன்வெர்ட் பண்ண முடியாமலே ஆகுது. ஹவு டு மேனேஜ்?
Sir, actually that management part is the difficult part. They are the true warriors.
Yes sir.
Identification is very simple. நாங்கள் 4 கேஸ் எமர்ஜென்சியில் பார்க்கும்போது ஒரு பொட்டன்ஷியல் பிரெயின் ஸ்டெம்னா பொட்டன்ஷியல்னு அவங்கள்ட்ட கை காமிச்சிடலாம். அதே மாதிரி ஒன்ஸ் கிளினிக்கல் பிரெயின் ஸ்டெம் ரிஃப்ளெக்ஸஸ் ஆப்சண்ட்னு சினாரியா வரும்போது தட் ஆல்சோ வி கேன் ஈஸிலி ஐடென்டிஃபை பண்ணி கொடுத்துடலாம். அதுக்கப்புறம் தான் ஒர்க்கே ஸ்டார்ட் ஆகுது சார். அவங்களோட ஒர்க் இஸ் அ டிஃபிகல்ட் டாஸ்க். தட் மெயின்டெனன்ஸ் பார்ட் இஸ் த மெயின் பார்ட். இது பண்ணும்போது ஏன்னா பேஷண்ட் வந்து சிங்கிங் பேஷண்ட் தானே, டெஃபினட்டாக மெட்டபாலிக் பேராமீட்டர்ஸ் அப்நார்மலிட்டிஸ் 1 by 1 வந்துக்கிட்டே இருக்கும். அதை தூக்கி நிப்பாட்டுறது தான் அவங்களுக்கு ரொம்ப கஷ்டம். மெயின்டெனன்ஸ் டீமுக்கு தான் மெயின் ரோல் அண்ட் அவங்களுக்கு தான் ஒரு ஹார்ட் டாஸ்க். இட்ஸ் ஸோ
பிரெயின் ஸ்டெம்னு டிக்ளேர் பண்ணுறதுக்கு எகைன் 3/5 4/5 இந்த டிஃப்ரென்ஸ் இருக்குது சார். இப்போ நியூரோ சர்ஜன் பார்த்துட்டு எல்லா ரிஃப்ளெக்ஸ் ஆப்சண்ட்னு எழுதிடுறாங்க சார்.
எஸ் சார்.
பட் அனஸ்தட்டிஸ்ட் பார்த்துட்டு ரிஃப்ளெக்ஸ் ப்ரெசன்ட் எழுதிடுறாங்க.
Sir, whatever it is, sir, let's treat the patient as a patient, not as a brain death. Gayatri alaha sonanga. Treat the patient first. Adu neenga gaunichingla? Treat the patient first.
As per ICU protocols.
Illiyo absent illiyo adha vitrunga. Treat the patient. Enakku vandu emergency la, because I receive all the patients and I was able to have a dedicated bed. So when we have a talk with the neurosurgeons, they tell us this patient might proceed for a potential. So we start maintaining. So it's like treating the patient. So ninga and the treatment part delaying nu nama sonnona, that means treatment is not happening. This is one of our Therni sir will tell us every time. If you are treating the patient properly, why does that patient go in for hypotension? That is, I still remember him. That is what he will say. If you are treating the patient at the 0 level, there is no cause for a hypercarbia or a hypotension. So you have to identify somebody at the entry point. And you have to allocate a bed there, allocate a team there who will be on guard all the time. Treat the patient. Don't worry about the GCS, don't worry about the reflexes. Keep treating the patient. At one point, the neurosurgeon or the neurologist or the physician or the surgeon, whomever is there, if they write on the case sheet it's an E1 VTM1 with absent reflexes, Dalsai impaired, we can proceed on to the apnea. So until then, the patient has to be treated. Only after they declare, the maintenance and optimization comes in.
Sir, one more point is, sir, apart from the reflexes, we have to go check for spontaneous respiration. If the reflexes may be present or absent, but if the spontaneous respiration is absent, you definitely have the chance of the patient declaring as brain dead. So what we do is, when the reflexes are absent, we definitely check for, as you said, cough reflex. After that, we watch for spontaneous respiration, either by putting the patient in Bain circuit or putting the ventilator in the apnea backup mode. So when we So sir said we will disconnect the patient from the ventilator. We put the ventilator, we don't disconnect the endotracheal tube, just put it in the apnea backup mode. So if the patient is having spontaneous respiration, it will be shown there. And moreover, in the CME mode, sometimes the set rate will be 14 and the patient may be taking 16.
Yes,
The reflexes may be absent, but the respiration may be there. So checking for spontaneous respiration is most important for me actually, because 2 cases we have denied. One case from IMCU they will be telling no response, the patient may be brain dead. But when we check for reflexes, the reflexes was, so we did not proceed with our protocols there. Another patient, he was shifted from Bangalore. The patient attenders were in Erode, but she was in Bangalore, where the hospital authorities said she is a probable brain death signs are there. So they brought here. When during the travel, maybe around 6 hours or some, the atracurium effect is gone, or I don't know. The patient was moving, breathing vigorously. So immediately we pointed out that she is moving and the spontaneous breathing is there. So we are not going to put her on brain death management. We can save her. The patient was around 70 years female. Then she was again taken to some other private hospital according to their will, the doctor's family. And the patient was saved without even tracheostomy, she was recovered. Okay. So we don't know on what basis the people in private hospital, they said maybe the travel, all the drug effect has gone and the patient started breathing on her own. So spontaneous breathing, I would say, sir.
Yeah, thank you, Gayatri. Actually, sir, you should not depend on a neurosurgeon or a neurologist. Every person there, all of us who are doctors there, can definitely go in and assess and see the patient for what normally happens is we pinpoint at a particular doctor. They are responsible for this program. They have to come. So, anta madri, if it's going to sit on one person, then the program is bound to collapse. It's a teamwork and more people have to be pulled into the program. So that delays like this does not happen. I hope we've answered your queries, sir. Yeah,
okay.
Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you. Question? After this, we can break for lunch, sir. Yeah. This last question.
I'll just make it very short, ma'am, and thank you for making this quality and intense discussions, ma'am. Ma'am, since the discussions were happening, there was mention about the 6 hours interval between various parameters, even before declaring, taking the first test and in between the 2 tests involved. Now, what is the time or the maximum time for between the 2 tests, number 1. Number 2, if the patient family does not agree for organ donation and you still declare a patient brain death with the second declaration, ma'am saying that it's a death time. If the patient still continues to breathe for more than 6 hours, what will be your time of death, especially in terms of the medical legal cases?
So
always, whenever there is a second apnea test, blood that is the time of death. ABG, which we are taking at the time of second apnea test, that is the time of death, medical legally.
Now, sir, this is just
prolong ஆறுது நம்ம கொடுக்கிறது கொடுக்காம இருக்கிறது willingness கொடுக்கிறது கொடுக்காது, that is all different. But as per the time of death அப்படிங்கிறது வந்து the time when we have taken the blood sample for the second apnea test, in that we have reached the PaCO2 target.
Now, sir, let us assume, sir, if your second declaration is 11:30 in the night, the patient continues to breathe till morning.
Not breathe.
Or, the heart stops rather. Yeah. What will be your date of
it will
death,
be
sir?
the time of second apnea, sir.
That is what I told
second
initially itself.
Apnea, the time of drawing the blood will be
I
the
got it,
time
ma'am.
of
I got
death,
it. I got your
whether
point.
they donate or not. Sir,
Yeah, I got your
Alahas,
point.
whether they donate or not,
I got your point, ma'am.
Time of death.
I am with you on that.
Date
no
and
second
time
thoughts
of
about
death
it.
you have to educate the matron, RMO, அவங்களெல்லாம் கூப்பிட்டு you have to educate them on this point.
Ma'am, this is not from the medical point of view. We also agree that. But since this case was a medico-legal case, we find it very difficult to convince the IO who came down there. He said that we will only take the time when the heart stopped.
No,
as
sir,
sir
it is
mentioned in his declaration time, there will be a special line on
Sir,
the
this rule is very clear, and it is mandatory, and it's been brought in by our Transplant officials also. So everywhere, universally, if we are going in lines of apnea testing, we suspect brainstem death in a patient, and we have done the apnea, the second apnea or the ancillary time in which the cerebral angiogram has been done will be the time of death, universally.
Yeah, I agree that, ma'am, but there is no documentary evidences to
Transplant
prove
guidelines
that
are there, ma'am.
Yeah, Transplant guide.
That's
Maybe
one. And
we have to
ma'am,
put.
and one last question, sir. You said in your contraindications you will not take assault cases. Is there any, thought
Unknown
blocks on
and
that?
assault.
Sorry, sir.
Only two. Unknown.
Is it
unknown mode
a
of injury.
contraindication in
Sir,
brain
now
death?
உங்களுக்கு ஒரு நான் உங்களுக்கு ஒரு எக்ஸாம்பிள் கொடுக்கிறேன். அதாவது we received a young girl, hanging girl, sir, married for 1 year. Her husband was murdered by her elder brothers. இது வந்து பேப்பர்ஸ்ல எல்லாம் கூட வந்தது. ஸோ ஹஸ்பண்ட் வந்து ஆணவ கொலை, அவங்க ஹஸ்பண்ட் இந்த ஒய்ஃபோட அண்ணன் பிரதர்ஸே மர்டர் பண்ணிட்டாங்க. Brothers are in jail. Now this girl is residing with her mother-in-law. That particular day when she committed suicide, partial hanging, she got a letter from the court saying that her brothers were being released. The moment she heard that, she locked herself into the room and she hanged herself. She was an E1-BTM1 with an impaired Alzheimer's movement. Now, these are patients which whom you do not want to proceed with. Adha sir mean pannar.
Why is that, ma'am?
There's going to be a lot of medico-legal implications in this patient.
Well, that's the reason why I wanted to bring this to the forum, ma'am. This was some 10 years before. A post-mortem doctor who conducted the post-mortem came forward and saying that I have no issues in allowing the retrieval team to retrieve the organs until I have a clarity on the cause of brain death. So there is no question of how the brain death occurred. So what is the status now, sir?
I don't understand, sir.
Sir, RTA, sir. RTA head injury.
This is purely a murder case, ma'am.
So usually in a murder, see what happens is head injury, the family might go to court next.
Well, in fact, they got a court order, ma'am.
It's already in court.
They got a court order for
donating.
organ donation. Yes, ma'am.
I think that has to be answered by Professor NGK, sir, because I do not know. Sir,
yes, sir. What he is saying is,
assault is not a contraindication, but in general there is so much of complex medical legal issues.
issues.
Because practically a lot of difficulties and so that's why we stay away. But actually it's not an absolute contraindication. Definitely it's not an absolute contraindication, particularly when the police officials have come in and the potential, the evidences, which may be relevant to the case investigation in future if all those things have been taken care of, and if you get a clearance from the police team, it is not an absolute contraindication. But in general, in a high volume center like MMC, we avoid because there is no kind of a specified team which can be just doing this work alone, because all of them, they have got neurosurgery or anesthesia, emergency medicine, they have got so much of other work. So that's why we kind of sometimes excuse ourselves and get away from that highly entangling issues. Otherwise, there is no absolute contraindication.
So with that, I think we can come to an end to this panel discussion. So we would like to thank Professor NGK sir for giving us this beautiful opportunity. He's been our mentor and he's been our guide at Madras Medical College. Without him, this program would never have reached so much of success. Thank you very much, and he's taken us all the way to New Delhi to receive an award from Health Minister. So we will always remember that. Thank you very much, and thank you to my panelists, Professor Balamurugan sir, Professor Gayatri, and Jayanti. Thank you so much.
I would like to say to the newcomers, please don't worry about the outcome. Transplant and our seniors are always there to help us. When we started with first case, second case, we had so many queries for which we got so much help from Transplant and MMC team. So definitely they are with us, and thank you very much, sir. Thank you, madam, for making it very simple.
Yeah, that's right actually. Like 24/7, there is someone to communicate, someone to lend a helping hand and clarify our doubts and so on. We all work as a single team, be it private or public. The entire state is very well connected, and we have mechanisms to clear your doubts as and when they arise and so on. No one is alone in the program, and no need to have any undue fear to be involved in the program. That is the final news. And once again officially congratulate the team Madras Medical College for bagging the national award as the best brain death certifying team of South India. Thank you so much, and please join us for lunch.